We have achieved 1 million lens implants. We are star, and infinity is the next milestone. We have achieved 1 million lens implants. We are star, and infinity is the next milestone. We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone. We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone. We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone. We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone. We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone. We have achieved 1 million lens implants. We are star, and infinity is the next milestone.
I welcome you all on the day 3 of 14th edition of Kalpavriksha. We had a fantastic day 1 and 2 where we learned cornea, cataract, oculoplasty and uvea. Today we have interesting sessions in glaucoma, squint and secondary IOLs as well. I am also learning in the process of this Kalpavriksha. We have a lot of good speakers from all over the world. I ask Dr. Soundri to take over the further sessions. Dr. Soundri is the head of CMH Agarwal's at Chennai and she is the co-moderator. She will take over.
Thank you, Dr. Divya. We welcome you all to the 14th edition of Kalpavriksha. In day 3, we are starting the first session. I take great pleasure in inviting Dr. Sonal Tuli. Dr. Tuli is a board certified in ophthalmology. Her interest includes cataract, corneal transplants, ocular surface cancers, dry eye disease, and infectious eye disease. She is on the board of Florida Society of Ophthalmology. Dr. Tuli has taught courses at international, national, regional, local conferences, as well as at the University of Florida. She has over 50 publications in peer-reviewed journals and is actively involved in clinical as well as laboratory research as a principal investigator and as well as a co-investigator. She is on the editorial board of peer-reviewed publications and a reviewer for several scholarly journals. She was invited and has served as an oral examiner for the American Board of Ophthalmology since 2006. We welcome you, ma'am. Today she is here to talk to us on corneal ulcer. We welcome you.
Thank you so much for having me, and happy Independence Day to everybody. Okay. But thank you so much for having me. I'm very excited to be here. So this is, I'm going to get started with, so I don't delay things. Let's see if I can get my PowerPoint up. Yes. Sorry, technical difficulties. Let me see. Won't let me share my PowerPoint for some reason. All right, let's go to a different, hang on. Do you want to go to the next talk and then come back to me?
Absolutely no issues. We can do that. So, because of the technical difficulties, what we'll do is we'll go for secondary IOLs. So, I'm going to introduce Dr. Kaladevi Satish, who did the talk on the first day. Hope you had listened to her. She's an excellent cataract surgeon, and any complication, she's the best person to handle. Who can be a better person to talk to us about secondary IOL other than Kala? We welcome you, Kala, Dr. Kala. You're muted.
Yeah. Thank you, Soundri. That was a wonderful introduction for me. I'm actually elated. First of all, today's topic is secondary IOLs. So I'll go to the share screen directly. So is the screen visible? Okay. So first of all, how do you define a secondary IOL? A secondary intraocular lens implantation is defined as implantation of intraocular lens following an initial surgery that resulted in aphakia or a deficient intraocular lens. So any surgeries taken after the primary surgery goes for a secondary implantation. What are the indications, common indications? As postgraduates, the first question is, what are the common indications for secondary IOLs? The most common indication is aphakia. Aphakia due to many reasons. IOL exchange, this becomes the commonest cause now, and any IOL rubbing the iris causing syndromes which needs to be removed, or any IOL causing any capsular bag infection or something, we need to remove the IOLs. So how do you evaluate? First of all, in those cases, you have to do an anterior segment evaluation completely, check for the angles, check for the iris stability, check for any capsular bag remnants are there, any sulcus is visible, anything in the posterior segment, if the view is better, a fundus evaluation is a must, and documentation of the fundus evaluation is a must for the patient in this medical legal world. The manifest refraction of the individual. So you can always tell the patient this much is your vision post-operatively you can expect. The vitreous management in the previous procedure, that is to be seen, particularly if there are any holes, tears because of the primary procedure. So we go on to how do we attack the case. So whenever you see an aphakia, first of all, you assess the capsule. Whether a 360-degree intact anterior capsule, sometimes you might see the whole capsular bag intact. They might not have placed the IOL, or only a rim is seen, whether iris is there. Based on that, you can go for a 3-piece IOL or iris fixation or an anterior chamber IOL or a scleral fixated IOLs. So these are the types of IOLs in our armatorium for the secondary IOL implantation. You can see the anterior chamber IOLs, you can see the iris fixated IOLs, the sutured scleral with, especially with the eye. These are the sutured scleral fixated IOLs, and the other IOLs in case when the bag is intact. So moving on, where can we implant the IOLs inside the eye? So when the bag is intact here, we can implant it in the bag or in the sulcus or over the iris in the chamber in the angle. These are the places where you can effectively control the IOLs. So we have to find a place to keep these IOLs. First of all, check for an adequate capsular support. If the capsular support is adequate, then place it in the bag, a single piece or a 3-piece IOL in the bag. If there is a sulcus support only and there is a posterior capsular remnant, then you have to keep a 3-piece IOL in the sulcus. Why I say 3-piece IOL? Later, for any modification, a 3-piece is always better than a single piece IOL. So these are the places where you can place the IOLs if these two are not there. One is in the anterior chamber, one is in the iris, or you can go to the posterior chamber either at the ciliary sulcus area or the bag or the transscleral fixation. Based on that, you have a many type of IOLs like anterior chamber IOLs, iris claw lenses, scleral fixated IOLs. In scleral fixated IOLs, we have the glued, the sutured scleral fixated, the Yamane technique, which is most popular. So we'll go one by one, the advantages and the disadvantages. So first is the anterior chamber IOL. This is, now we have stopped doing this because of many complications. There are two types like the angle supported IOL, and this is the Kelman flex IOL. You just place the anterior chamber IOLs inside the bag and close inside the eye. The iris support should be intact for this. What are the problems with the anterior chamber IOL? You expect endothelial loss, a corneal decompensation leading to bullous keratopathy. Angle might form PAS and you lead to glaucoma or pressurized peripheral anterior synechiae. Any malposition might lead to problems, a recurrent uveitis. Sometimes you have to have a broken haptic while inserting or iris chaffing. And finally, the posterior segment, we have the cystoid macular edema. So this is a format for a sutured scleral fixated IOL. I don't have a video for this, so I've just put this picture for you people to understand how it is being done. You can follow the arrow mark. Here is the signal actually. Can you see? Here is the section which is made. 2 scleral flaps are made accordingly. Based on the 27 gauge, with a 27 gauge needle, a 10-0 prolin is passed inside the flap and it is taken out through the needle. And then it is passed up-down manner in the scleral fixated IOL without a knot. And the second pass is also brought out and passed outside. Similar way, the other side of the flap, the needle is passed, but in this case, it is down up and it is brought out without any torsion outside. So these two knots are pulled outside like this, and the IOL comes and centers, and the knot is being done. Actually, it is a 4-point fixation IOL for us. So what are the problems with sutured SF IOL? This was the IOL for practice for long years and retinal surgeons used to manage. The problems with these IOL are the surgical expertise. Definitely needs a much surgical expertise on the suture passing and everything, and prolonged surgical time. It has a suture-induced inflammation. The sutures get degraded. There is pseudophacodonosis and sometimes endophthalmitis and late IOL decentration because of the sutures rubbing. Then we move on to the iris claw lenses. The iris claw lens is a relatively simple design, one piece, one material. The fixation mechanism is basically on the enclaving mechanism. You can see the break there. The higher oval, the thinner the haptic here, and it is a plate haptic mechanism with a big oval here. First of all, I would tell the postgraduates that any secondary IOL implantation, the first surgical step is, I would prefer to put a posterior infusion, because you can always see a great lot of surprises in the posterior chamber. You can see IOLs coming up, or you might have missed during the preoperative examination. So always go for a posterior chamber infusion, and with IVTA, go for a thorough vitrectomy. Then this is an iris claw lens. So the section is slowly extended. The wash is being done. The iris claw lens is slowly brought inside the eye, and you can see the enclaving being done on one side, and slowly pull the iris, bring the haptic down and enclave it on the other side. So this is a simple procedure, and this is the first post-op. The second video here, which I'm showing you, is the Yamane technique, which is a recently developed technique and which has good appreciation outside. And there are many modifications in these technique which are coming up. It is an intrascleral fixation technique with a 3-piece IOL. So what you actually do is, in basis of, you make 3 markings with a marker about 1.3 to 1.5 mm in diameter. The same step, do a thorough vitrectomy, and then you pass a 26 gauge needle horizontally in one plane, and then you enter into the chamber. So this is a modified technique. You can see the haptic being passed slowly into the 26 gauge needle. This procedure should be very gentle, or else the haptic might dislodge from the needle. You slowly bring out the 26 gauge needle outside, and you cauterize the tip of the haptic. Then press up the haptic slowly so that you make a bulge there, and slowly push it under the conjunctiva. Then this part of the IOL is safe. You go with the second haptic. Bend the second haptic down slowly. Catch with this. This is the handshake technique by Dr. Amar Agrawal. You hold the haptic in a comfortable position. Then you pass the needle in the same way into the eye. And this step is the most difficult one. You have to slowly push the haptic into the gauge of the needle, 26 gauge needle, and bring it outside. After making sure the haptic is enough and well centered, then you cauterize the tip of the haptic. The same mechanism is repeated, and press the bulge so it makes as a bulge, and then push it under the conjunctiva. And thus, this is the end of the Yamane technique. So this technique is actually very good, and many people are following. But one problem is this fixation goes more posteriorly. So the chances of losing the IOL on table is high for a beginner. And one more thing, this haptic erosion, we have to learn and understand the long-term studies. This is the popular next technique, which I come from the end of glued IOL. So this is a glued IOL technique. The same way you create 2 flaps which are 180 degrees apart. 2 sclerotomies are made. A thorough anterior vitrectomy is being done. Slowly the haptic is inserted. The tip of the haptic is held and the IOL is increased. You can see the C sign there. When you see a C, then the IOL is coming in the right direction. Hold the second haptic, bring it out through the sclerotomy. You have enough time to center the IOL, which side the IOL is centered. You pass 2 Chariot's tunnels with the needle, and then pass the haptic under the Chariot's tunnel. Then you seal the scleral flap with the glue. So the conjunctiva is also sealed with glue. This is a video for a comparison of the pseudophacodonosis seen in a glued IOL technique and a iris fixated. This is the anteriorly fixated iris fixated lens. You can see the movement of the IOL. The movement in the glued IOL part on the right side is slightly less on movement of the eye, whereas in the iris fixated, you can see a lot movement seen, the pseudophacodonosis being present. This is a slow motion video of the same movement. You can see the iris and the IOL frame, how it is moving in an iris fixated IOL. Whereas in a glued IOL, you can see the fixation perfection there. So the rubbing chance and everything is very minimal here. So this is about the 3 techniques. So I move on to next comparison of these techniques. So there is a lot of pseudophacodonosis in the iris fixation when compared to the glued IOL technique. And one important advantage of glued IOL is it is exactly at the same anatomical plane where a normal IOL is placed. So same IOL power calculation, and no extra instrumentation is required on the table. The surgical curve is relatively easy, learning curve. One of the important advantages is it also can be combined with other surgeries like any nucleus drop or aniridia IOLs or a multifocal IOLs. You want to glue it, you can definitely go ahead, adjust the centration based on the tucking process, and you can also be associated with a PDEC, DMEC and DSEC surgeries. So suture related complications are much lesser here. The centration is possible in a gluteal. The endothelial loss is very minimal. UGH syndrome is very minimal. So these are the main advantages of them. Whereas in an iris claw, I feel that there is microhyphema, and these are from the studies. So there is spontaneous disenclavation which is happening, and it prevents infrared transmission in the OCT. So Yamane technique is good. Many modifications are coming out in Yamane technique and people are trying out. But the only thing I feel is the IOL is more posteriorly placed. And as a beginner, when you lose one haptic along the track, you have to definitely go for a second placement or second incision of the needle, because the chance of losing the haptic is more. Whereas in a gluteal, even if you lose the haptic, you can always pass the MST forceps again through the same sclerotomy and bring it out and tuck it back. Thus, gluteal becomes a one-stop solution here for all defects like a corneal decompensation, for any iris defects, for any capsular defects, or a complete absence of iris like an aniridiol, or in combination with other surgeries. The secondary IOLs, first, I would like to conclude saying secondary IOLs, the first attack for the PGs is the pre-operative evaluation. Assess the eye, assess the status of the eye. As I told you, the anterior segment evaluation, the posterior segment evaluation, how is the vitreous managed in the primary surgery, documentation of the primary surgical eye. So when you see the eye, document what is the corneal finding, how much is the specular, how much is this, so that everything is safe. Then you plan what procedure to be done. If the capsule is intact, obviously we go for a capsular bag implant. If the sulcus is there, go for a ciliary sulcus implant with or without optic capture. In case of secondary IOL, there are various techniques which I have told you. Definitely, I would go for whichever I am comfortable. I would go for my gluteal technique, or you can opt for any other technique. But this gluteal is safe and potential alternative, and I prefer it because it is same anatomical plane compared to others, and it is more cost effective. You need not have a special IOL in your table. You can use the simple APA 3-piece IOL which is in your IOL lab, and you take it out for the power and you implant it. Thanks for the opportunity. I would like to thank Dr. Ashwin and Dr. Soundri, Dr. Divya for giving me this opportunity, and my pranams to Dr. Amar Agrawal who has taught me this wonderful procedure. Thank you, sir.
Thank you, Dr. Kala, for taking us through the armamentarium of secondary gluteals. Thank you so much. Dr. Sonal Tuli, are we good to go? Sorry, you're muted. I'm not able to hear.
Can you guys see my screen now?
Yes.
Okay, perfect. So sorry about that, and that was a hard talk to follow, so I'm going to try to do my best now. I thought I could get my talk out of the way before all the great talks went, but I'll do my best. So we're going to talk about corneal ulceration, and you are all very familiar with corneal ulcerations. I'm sure, just like we do in Florida, you all see hundreds of these. So what we're going to focus on is basically looking at corneal ulcers and starting to think about what these might be so that we can figure out how to treat them. And then we'll go through some of the treatment protocols for these. I have no disclosures. I will talk about some off-label uses of medications though. So we'll start with the easy ulcers, bacterial ulcers. You see hundreds and hundreds of these. But again, when you see an ulcer, you need to start thinking, is this a gram-negative or a gram-positive ulcer? Because that would make a difference to how you would treat these patients. So with the gram-negatives, as you know, lots of inflammation, lots of purulent discharge from the eye. Because there's so much inflammation, there's a hypopyon. But remember that these hypopia are reactive hypopyon. It's because there's so much inflammation. So that does not necessarily mean that there's an infection in the eye. But there'll be a lot of discharge. There'll be lots of soupy cornea because the cornea is getting necrotic. The edges will not be very well defined because it's growing very, very rapidly. And you might have an early ring starting. As opposed to a gram-positive, in this, there's a little bit less inflammation. There's still inflammation, but it's not as severe. So you might get less AC reaction, less purulent reaction, more sharp borders. And sometimes if you try to scrape these ulcers, you might see it fluctuate a little bit, like a little abscess in there. Now, these obviously are very pretty. All of the trainees should know immediately what this is, but this is crystalline keratopathy. But the reason it looks so pretty is because there's no inflammation at all. And that's because these are usually in patients who are on immunosuppressants, on steroids. And these are basically chains of bacteria, chains of strep viridans that are growing within the corneal lamellae. And they look very, very pretty because they also form a nice little glycocalyx around them, which walls them off. But that also makes them very, very difficult to treat. But when you see these beautiful snowflakes on the cornea, you immediately know what you're dealing with in terms of an infection. Now, this is another snowflakey looking appearance. Again, a very dry ulcer, but immediately everybody in India should know what this is. These are pseudopods, again, growing within the cornea. But you can also see mutton fat keratic precipitates. This was a patient post LASIK. He actually had a cat that had a fungal ulcer who slept on his head every day, and also slept on his head on the day of his LASIK surgery, and he got this infection a couple of days later. But one of the other things you look for when you're looking for a fungal ulcer, rings are very common in fungal ulcers. You also see satellite lesions, as you can see in the bottom right corner. And then you have these very classic features, which I call a formed hypopia, right? So when you saw in the Pseudomonas ulcer, you saw that there was a boat-shaped hypopion, which tells you it's a reactive hypopion. These are PMNs that are lining up in the anterior chamber and layering out. In fungal ulcers, though, you get these hypopia that have a shape of their own. They have a mind of their own. And that's because fungus can actually get through intact cornea, unlike bacteria that usually need the cornea to perforate before they enter the eye. Fungus can actually go through the cornea and form these hypopia. And these hypopia are not reactive. These are actually fungus in the eye. Another branching ulcer, but again, the residents immediately should know when they look at these that you've got dichotomous branching, so two branching in twos, and then they've got terminal bulbs, and fluorescein stains the center. If you put rose Bengal, it would stain the periphery. So most people looking at this would immediately say this is a HSV keratitis. So much easier to see, and its appearance gives it away. Unfortunately, stromal HSV is not as easy to diagnose. And so when you see these little discs of edema on the cornea, especially if you see keratic precipitates lining up right under the disc, this is endotheliitis, or what we used to call disciform keratitis. So if you look at a cornea and there's a disc of edema, but the rest of the cornea looks relatively normal, start thinking of HSV, especially if you see these mutton fat KP, keratic precipitates on the endothelium. So this is endotheliitis. The cornea itself is not involved, the endothelium is, but the cornea is swollen because the endothelium cannot function. The other thing that we see commonly, especially in the US, the most common cause of interstitial keratitis is actually HSV. So you'll see these blood vessels, you'll see inflammation in the stroma, but the epithelium and the endothelium are relatively unaffected. Now here the epithelium has started to break down. But these interstitial keratitis are, again, very common with HSV. Again, what you would do is check a corneal sensation. And because HSV causes damage to the trigeminal ganglion when it replicates, you would see lack of corneal sensation when you see these ulcers. So when you see interstitial keratitis, check that. Now, HSV, especially if it's recurrent, or sometimes with HSV2, you can get ulcers very similar to Pseudomonas ulcers or gram-positive or gram-negative ulcers, where you can see a lot of necrosis, you can see a hypopion. But again, look for these mutton fat keratic precipitates, look for the fact that there is not a whole lot of inflammation, not a lot of mucopurulent discharge. And if you check this patient's corneal sensation, it will be decreased. And these patients will not complain of foreign body sensation like your bacterial ulcers do. They won't come in holding their eye because they cannot open it. They will be comfortable. They might have light sensitivity, but they won't have foreign body sensation. And of course, late in the disease, when you have interstitial keratitis, you can leak lipid out of there, and you can get lipid keratopathy, which can cause a sudden loss of vision. But when you see these features, start thinking HSV, even if you don't see the dendrites. Now, this is a disease that, again, you are probably very familiar with, but it's classically misdiagnosed as HSV. But these are contact lens wearers. They come in with very severe pain in the eye, and they'll have dendrite-looking lesions on their cornea. These are very superficial lesions initially, But again, they won't look classic like HSV. They won't have the dichotomous branching. They'll branch every which way, and they won't have the terminal bulbs. So these are all features of acanthamoeba, especially with the severe pain. But early on, you can get these raised epithelial lines that very classically look like HSV. But when you see a patient with a contact lens wearer who comes in with an HSV and severe pain, think of acanthamoeba. But they can also have ring ulcers. But these deep stromal infiltrates, scattered stromal infiltrates, should again make you start thinking acanthamoeba in a contact lens wearer. And then when you see these perineuritis, these nerves with inflammation around them, that gives you the diagnosis that's pretty pathognomonic for acanthamoeba keratitis. So these are some of the features that should make you start thinking this may be what's going on. But obviously you want to prove that you know what's going on in the eye, and you want to know what the organism is that's causing the infection. So you want to do a culture. And typically in cornea, we do the cultures and plate the specimen directly on the plates. So I usually tell my residents get the strawberry, chocolate, and vanilla plates. And these are for bacteria. The Sabouraud plate, the vanilla plate, actually has an antibiotic in it, which is specific for fungus, because fungus can actually grow on pretty much any plate, but the bacteria will overwhelm it. If you put it on the Sabouraud plate, because it's got a little bit of antibiotic, it'll prevent the bacteria from growing and you can grow the fungus. The thioglycolate broth will help you with anaerobes. And then I always send at least 2 to 3 slides so they can do a gram stain, GMS. We do silver stains. We don't have KOH here. So we do silver stains for fungus and acanthamoeba, sometimes calcofluorite, and viral culture media. I like to use this double-sided blade, which is called a 69 blade here, for doing the cultures, because it's not very sharp, especially in the hands of my trainees. I'm not as worried that they'll poke a hole in the eye doing the cultures. So once you know what you're dealing with, how would you treat it? So with bacterial, you need to use fortified antibiotics. If you don't know what you're dealing with, I usually put them on a gram-negative and a gram-positive treatment. You can use either tobramycin, gentamicin, ceftazidime, or a fluoroquinolone. If you know you're dealing with a gram-negative, then you would use 2 gram-negative treatments. Tobramycin, gentamicin in this country at least have very low resistance to bacteria, or bacteria have very low resistance to tobramycin. So it's a good medication to use topically in ophthalmology. Now, why do we use it so frequently, every half an hour? Do you know how quickly bacteria replicate? So if you look at Pseudomonas doubling time. So 1 Pseudomonas becomes 2 Pseudomonas in 20 to 30 minutes, which means in one day, 24 hours, 1 Pseudomonas bacteria can grow into 280 trillion bacteria in 24 hours. And so it's growing very, very rapidly. So if you don't put antibiotics in very, very frequently, then by the time you put the next drop in, that bacteria, the bacteria that you have in the eye, have doubled, tripled, quadrupled, and you're just going to be chasing the infection. And so treat it very, very frequently. Some people will put it in every 5 minutes initially, just to try and kill as much bacteria as you can. And then, of course, once you know what you're dealing with, you change it based on the stain and the cultures into gram-positives or gram-negatives. I always put them on a cycloplegic for the pain, but also because they have so much inflammation in the eye, you want to prevent them from causing scarring and causing posterior synechia, which can then lead to other problems down the road. Oral and subconjunctival are really not needed in patients typically, because the amount of antibiotic you can get from topical medications is so much higher than what you can get orally or subconjunctivally. But sometimes if you have patients who are not very cooperative, or you don't think would put the drops in, you can supplement with these. Again, remember that it's not the inflammation in the eye is typically not an infection. Now with the fungus, you want to treat it a little bit differently. You don't have to be as frequent, because fungus doesn't grow quite as rapidly. So you don't have to put it in every 30 minutes or every 5 minutes. So usually I'll put them on 2 different medications. I like using 2 medications for no matter what I treat. That way, if they're resistant to one, you're covered. Excuse me? Okay. Can you hear me? Hello? Oh, okay. Somebody said something. I'm not sure what they said. But so they don't. So, and again, with fungal ulcers, you want to treat them with different medications. but often you want to treat them with 2 medications. I usually put, so Candida, you would want to treat with voriconazole and amphotericin. Filamentous fungi, I usually treat with natamycin and amphotericin or voriconazole. And then for aspergillus, natamycin and voriconazole are the drugs of choice. Now, in these conditions, I would be much more likely to treat them with an oral medication and give them intrastromal or intracameral medications as adjunct, because 2 reasons. One is the antifungals don't penetrate into the eye very readily. And secondly, when you see this formed hypopyon, you know that there is an infection in the eye, and treating it from both ends, topically on the surface, and then treating it orally or intrastromally, intracamerally from the inside, will be much more likely to treat these. And again, you need to treat these for much longer periods of time. But despite that, they often end up needing surgery more frequently. Acanthamoeba, again, dual therapy. I treat them with a biguanide, and sometimes we treat them with actually both PHMB and chlorhexidine, because it's very hard for us to get the pentamidines and the hexamidines in this country. But typically, you'll treat them for both these medications, and these are treated for a very, very long time, for at least 6 months. You could add oral voriconazole or miltefosine to these medications to get a little bit more efficacy. HSV is very different treatment, whether you're treating with epithelial disease or you're treating the stromal disease. With epithelial disease, gentle debridement, actually with a cotton tip applicator, just rubbing the cornea and taking all the infected cells off, works very well. You can treat them with topical or oral antivirals. And then with the stromal, though, you need to treat them with steroids, but cover them with oral antivirals. Necrotizing, you want to treat them with all kinds of antivirals, topical and oral, and also with topical steroids. How about steroids for ulcers? Well, overall, for SCUT study, they found no benefit or harm when you use it for bacterial keratitis. If you have deeper, central, larger ulcers, could benefit. Never with fungal or nocardia, obviously. Acanthamoeba is a little controversial, so think about it before you put them on it. And HSV, you always want to treat it with the stromal or endothelial, but never with the epithelial disease. We use doxycycline and vitamin C very frequently because inflammation equals proteases. Proteases cause melting of the cornea, and these inhibit the MMPs. Vitamin C acts as an adjuvant. We'll sometimes use amniotic membrane, especially for non-healing ulcers, again, put the sticky side down, because it has anti-inflammatory and anti-VEGF agents in it in the stromal side, which could help. Gluing, I love gluing, especially for peripheral ulcers. It works very well. It prevents inflammation or infection from advancing. And once you heal the ulcer with the gluing, you sometimes don't need to do anything else, and they don't need any surgical interventions. Corneal transplants you are very familiar with, but you don't always have to do a very large central corneal ulcer, especially if you have a peripheral. This was a fungal ulcer that developed in a cataract wound. And I did used a skin punch to do a 4mm trephine. It worked very well. You don't have to worry about it rejecting, because even if it rejects, you have enough endothelial cells to cover it. And so these do very, very well. Sometimes if you have a really bad ulcer that's very progressive, you might need to do a corneal scleral graft. These unfortunately don't do very well, they reject, but they can be an eye-saving procedure before you do a keratoprosthesis down the road. And that's all I have. I think I kept mostly to time. Thank you.
Thank you, Dr. Sonal. That was an excellent talk.
Thank you.
Wonderful pictures there, and you cover, I think, all aspects, the clinical part, the microbiological spectrum, as well as the treatment. It was a wonderful talk. Thank you very much, ma'am, and we hope you enjoy the rest of your weekend.
I will. Thank you so much for having me.
Thank you, Sonal. Sonal, thank you so much for that great talk, and thank you for coming today.
Thank you.
So our next speaker is Dr. Preetham. Sir, are you there?
Yeah, yeah, very much sure.
Preetham is there.
A very warm welcome to you. It's my pleasure to introduce Dr. Preetham. He's a very experienced vitreoretinal surgeon, currently with
We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone.
Up at another time. So starting with the topic of diabetic macular edema, as we know, the spectrum of disease in diabetic retinopathy essentially consists of retinal hemorrhages, vascular tortuosity, then the lipid deposits in the outer plexiform layer, what we call as a hard exudates, the cotton wool spots, which is essentially the exoplasmic stasis, and the microaneurysms, which are outpouchings of the vessels. Now, this is the classical description of clinically significant macular edema, which was described by the early treatment diabetic retinopathy study, the ETDRS, and which we followed for so many years when we had only laser as one of the modalities. And this is essentially involves three main pillars, that is hard exudates within 500 microns from the center of the FAZ, retinal thickening, which is within 500 microns of the center of FAZ, a larger area of retinal thickening, that is about 1500 microns, but which is within 1500 microns from the center of FAZ. So these three criteria were important to classify it as clinically significant macular edema. Anything outside this was considered not clinically significant. But now, as we have evolved with the advent of pharmacotherapy, intravitreal pharmacotherapy, the working classification or the more practical classification that we follow is the one which says whether it is center involving DME or non-center involving DME. So if there is no retinal thickening or hard exudates, it's not considered as DME. Any retinal thickening in the macula that does not involve the central subfoveal zone, that is 1 millimeter in diameter, is considered as non-center involving. And anything which is within that particular zone is considered as center involving. Now, why it is important to classify this as center and non-center involving is the center involving DME is going to have its largest impact on central vision. So, it has been shown that the impact of DME, there is a gradual vision loss in DME. Now, unlike age-related macular degeneration on the left over here, the trials have shown that age-related macular degeneration causes a precipitous and quick fall of vision over a period of time. But unlike that, diabetic macular edema seems, the vision loss seems to be gradual. So that is the window of opportunity that we as ophthalmologists have. If the vision loss is going to be gradual over time, then we have the opportunity here to stop the disease, to try and reverse the disease and prevent this vision loss. What investigations are required when you look at a case of diabetic macular edema? Now, fundus fluorescein angiography, although it is, the frequency of doing FFA is going down, it is very important to keep in mind that there are certain aspects of DME that cannot be otherwise detected by OCT alone. Like, for instance, macular ischemia. Macular ischemia can only be seen on FAZ. So when you see this distortion of the foveal avascular zone or enlargement of the foveal avascular zone, you know that this patient has macular ischemia. This patient, the visual prognosis is going to be poor no matter how you treat this patient. Then the OCT angiography is one investigation which can pick up this foveal avascular zone enlargement also. The OCT is one of the most commonly done investigations for diabetic macular edema, and doing this is a must.
Thanks. I
think someone's mic is on. The others should switch off their mic. Yeah, that's better. Thank you. So, the OCT angiography forms the mainstay of investigating and treating diabetic macular edema. On OCT, we can assess the type of DME, whether it is a focal DME, whether it is diffuse, non-cystoid, whether it is cystoid macular edema, whether there is vitreomacular traction because of an epiretinal membrane that is causing anatomical traction, whether there is subretinal fluid. There are certain OCT biomarkers which tell us whether the disease is severe. So these are described as DRIL, which is disorganization of retinal inner layers, hyperreflective foci, subretinal fluid, vitreomacular traction, cystoid macular edema, and disruption of the ellipsoid layer. These are some of the markers which tell us of a poor prognosis. So this is how, if you have the OCT, when you see these hyperreflective foci, you know that this kind of a diabetic macular edema is going to have a poor prognosis. That brings us to the treatment. So what should be the goals of treatment for diabetic macular edema? Now, the most important goal of treatment is to improve or stabilize the vision in diabetic macular edema. This we achieve by reducing the amount of macular edema, by reducing the leakage on FA, and reduce the thickening on OCT. Of course, this cannot be done alone. One has to take care of the systemic status of the patient also. So controlling blood pressure, controlling blood sugars, controlling lipids, this goes hand in hand with treating the diabetic macular edema. What armamentarium do we have in the treatment of diabetic macular edema? We essentially have laser photocoagulation, we have injections which are steroids and anti-VEGFs, and then there is vitrectomy. When we look at systemic management, we have a lot of trials which have studied on how to effectively systemically manage diabetic disease so as to control the DME. We will focus our approach on the ocular management. So what is important is to decide what is the best approach, whether we will use monotherapy or combination, whether we will use laser or pharmacotherapy. In pharmacotherapy, whether it is steroid or anti-VEGF. Now, every diabetic macular edema is going to be different, and a tailor-made approach is best suited to deal with diabetic macular edema. So what are the deciding factors? So systemic comorbidities will help us decide. The OCT pictures, the OCT types which I described before, they will help us. FFA picture, whether the macular perfusion is good or not, the chronicity of the diabetic macular edema, the age of the patient, the ocular status, whether the patient is phakic or pseudophakic. These are some of the deciding factors when we decide how we are going to treat diabetic macular edema. Now, if you look at the treatment over the years, over the decades, laser was a gold standard still about 2 decades ago. But it seems to be shifting now from laser to anti-VEGF. Although we have not given up laser, the shift is going towards anti-VEGF. Now, why is it so? Because we are trying not just to prevent further blindness, but the aim here is to even improve the vision. So that is why this paradigm shift in management has come. See, remember when we used to do laser, we used to explain to the patient that the counseling was that your vision is going to stabilize. You know, we rarely were able to tell the patient with laser that your vision will improve. Like there are a lot of studies also which have shown that the inadequacy of laser is in improving vision. It is more or less able to stabilize vision. The other thing is, you know, some of the drawbacks of laser is in diffuse DME or chronic DME, the DME, the edema rarely responds to laser. Another problem is if you have leakage bang at the fovea like this, then you can't laser the fovea obviously because there will be a lot of photoreceptor fallout. You will be causing a lot of retinal pigment epithelial atrophy, a lot of central scotomas. So these are some of the drawbacks of laser. So that's why we have shifted to targeting a different pathway in the pathophysiology of this disease, and that is the vascular endothelial growth factor. And so we have the VEGF inhibitors. And we have again a lot of studies which have proven the efficacy of anti-VEGFs for diabetic macular edema. Here's a straightforward case where this patient presented with diabetic macular edema. You can see all the spectrum of the disease here. You can see the FFA showing the FAZ is pretty good over here, but there is a diffuse leakage. You can see the OCT showing diffuse macular edema. Following 3 injections of Lucentis or ranibizumab and some laser at the end of 3 months, you can see how the edema has come down and the OCT has improved. But mind you, this disease requires follow-up. Sometimes repeat injections are required over a period of time. Some more laser is required, and then you can have the DME coming back. So this patient has a follow-up of almost over 9 months. You can see how the disease keeps on waxing and waning with the help of treatment. What about steroids? So besides anti-VEGF, there is steroids which we use for diabetic macular edema. Of course, the downside of steroids for the eyes is the development of cataract and secondary steroid-induced glaucoma. But the edge they have over anti-VEGF is that they are long-acting and they are suitable in systemic comorbidities where you don't want, especially when the patient has had history of stroke or any cardiac disease. There probably you would be a little wary to use anti-VEGF. There the steroids come into the picture. The rationale of steroid is in the pathophysiology of DME, it may not be just the VEGF, but there may be an inflammatory pathway playing a role. And the steroid targets this inflammatory pathway and helps the DME to resolve. There have been enough, there are also steroid implants available for diabetic macular edema. The Iluvian or the fluacetone implant and the Ozurdex, the dexamethasone implants are available for diabetic macular edema. So if you put it in a nutshell, the management of diabetic macular edema, where do you place all these three modalities, the anti-VEGF, laser and corticosteroids? So ranibizumab or anti-VEGF is in the early part of the disease. When you're seeing a diabetic macular edema for the first time, you would start with an anti-VEGF. If your anti-VEGF is not able to control the diabetic macular edema, you would probably put some laser over there, some focal or grid laser, what is also called as a rescue laser. And in the chronic phase of the disease, if the DME still persists because of some inflammatory pathology there, then you would go for steroids. So this is how an approach would be. Now here, what deserves a mention over here is the DRCR NET trial. Now this is one of the landmark milestone trials which was done to compare the laser treatment versus pharmacotherapy treatment. Now I'll put it in nutshell over here. Now these two, the yellow and the orange lines which you're seeing, this graph shows you the improvement of vision over the period, over many years after starting treatment. The blue and the orange is essentially the anti-VEGF with laser, whereas this purple is just laser. So you can see how poorly just only laser is doing in bringing the diabetic macular edema under control as compared to these two arms. In fact, the arm which is the blue one is the anti-VEGF, after which laser has been given after 6 months, so deferred laser. Whereas the orange one was when the laser was given along with anti-VEGF. So this also seems to have an edge over this. Now, what is the question here is this yellow. Now, this yellow was the steroid arm. Now, why is this yellow doing so good in the beginning? That is few months after starting, and why it has dropped here? That is because the steroid causes the cataract. That's why after cataract, the vision goes down. So if you look at when this graph is corrected, when in pseudophakic patients, the steroids do as well as the anti-VEGFs. So this is evidence which has proven that a combined approach, probably anti-VEGF with laser, was definitely superior to just laser for diabetic macular edema. And mind you, for our Indian scenario where the patients may not afford the expensive injections, bevacizumab or Avastin also works equally well. This is a patient where we treated with 3 injections of bevacizumab with some rescue laser at the end of 6 months. And you can see how the edema has come down. You can see some laser burns here. You can see the OCT showing improvement with the foveal contour coming back. This brings us to another aspect of diabetic macular edema, that is what about dosing? Now as we know that these injections have a certain half-life in the intravitreal cavity. So you have to repeat these injections. So is there a protocol which we can follow, how often these injections are to be given? Now there have been a lot of protocols which have been described, the monthly protocol, the wait and extend, the treat and extend, the PRN, that is as and when required, bi-monthly protocol. So essentially these protocols form into 2 groups. The fixed treatment protocols where you've decided in advance what you're going to inject, and PRN where you call the patient every month, you look at his OCT and vision and you treat it. Now both these protocols have plus points and minus points. In predetermined protocol, the plus point is that the patient has a certain fixed visits, but the downside is that you may overtreat or undertreat the patient. The as and when required protocol, the advantage is that the treatment is tailor-made to the patient. But the downside is that if the patient comes late to you, then the edema has come back, then you have further loss of vision. So this is a downside. So what the midway, what has been found is the treat and extend protocol. So the treat and extend protocol is currently the most accepted and the most popular protocol. In the treat and extend, what is done simply is after first 3 injections at monthly intervals, you simply go on increasing the interval between each injection. But if at any visit you feel that the edema has come back, then you go to this interval. So you go on increasing the interval, but at any visit you feel that it's not good enough, you go back to the previous interval. So this is called as a treat and extend protocol, which we nowadays currently use. We have a retained study which has proven the efficacy of this protocol. There is another study called as a luminous study, which has shown that on an average over a period of 1 year, you require about 4 to 5 anti-VEGF injections and 8 visits to control your diabetic macular edema with almost 3 to 5 letter gain in visual acuity. So there is enough evidence for the treat and extend protocol in diabetic macular edema. This brings us to the last aspect of diabetic macular edema, that is vitreomacular traction, where you have a membrane, a pre-retinal membrane growing on the surface of the retina, and this kind of edema will never respond to a laser or intravitreal pharmacotherapy. Here you are left with no option but to do vitrectomy to remove this epiretinal membrane, and then the edema will go back and subside and the anatomy will be restored. So the final part of the concluding remarks here is, how do we choose the best treatment plan? So like I said in the beginning, if you have a non-center involving diabetic macular edema or a focal edema, then laser is still the gold standard. Laser here will be best, it will be effective and will cause minimal damage. So like you can see over here, this is a case of focal edema over here. We did laser, you can see the very light laser burns here. And with this, all these hard exudates and these retinal hemorrhages have resolved in this patient. If you have a diffuse center involving diabetic macular edema, then combination treatment or monotherapy with anti-VEGF works the best. So if you have a diffuse edema, I will start with anti-VEGF and may or may not give laser. But if you have a diabetic macular edema which goes into the chronic phase, even in spite of injecting or giving laser, then you will switch to the steroid option, either Ozurdex or triamcinolone. Again, like I said, if you have vitreomacular traction, then you have to peel the ERM and the ILM. Of course, then there comes a subset of cases where, which do not work at all with treatment over a long period of time. Then you may even consider doing pan-retinal photocoagulation, or you may consider doing vitrectomy and peel the internal limiting membrane. This also has shown to help in certain cases of recalcitrant diabetic macular edema. Just before concluding, I would like to, one or two slides on the future of diabetic macular edema. So the other anti-VEGF which nowadays we also use is aflibercept or Eylea, which also has shown good promise. The protocol T of this particular trial has shown that it is good enough as compared to Accentrix and Avastin. There are sustained release steroids like fluocinolone, acetonide, and dexamethasone, which have been studied extensively. And now one thing which is on the horizon is the sustained release device of ranibizumab. This is gone into its phase 3 trial. It is called as a port delivery system, and there is a Pagoda trial which will soon release its data, where ranibizumab will be about 100 milligrams per ml of ranibizumab in a small device which can be injected and refilled at 6 monthly, will keep diabetic edema under control over a sustained period of time. So this is another thing in the future which we can hope. So with this, I conclude my talk. Thank you.
Thank you very much, sir. It indeed is a very vast topic, and I think you've touched upon it beautifully, especially the salient studies which have been done and the main take-home messages of each of those studies. I think that's an important question for most of the postgraduates. Thank you very much, sir, for a wonderful talk.
Thank you so much. Thank you.
So our next speaker is Dr. Mohit Dogra. He's an assistant professor at Advanced Eye Center, PGI Chandigarh, which is also his alma mater. At a very young age, Dr. Mohit has a stupendous achievement of over 55 publications, 42 presentations, and various conferences. He has also authored 16 chapters in various books. He is also an associate editor of IJO and is also a reviewer of many index journals. He has received many awards in various young ophthalmologists forum. We invite him to deliver his lecture on another important topic for the exams, age-related macular degeneration and its management. Over to you, Dr. Mohit.
Thank you, ma'am. Am I audible and are my slides visible?
Yes, you are.
Oh, great. So at the outset, I'd actually like to thank Dr. Agarwal, the entire team behind Kalpavriksha, and a shout out to Dr. Sondari who at the last minute was able to, guide me through some of the problems that I had logging in. So thank you. And I, would like to apologize to begin with on behalf of Dr. Mangal Dogra and to the audience if there were some people tuned in to, actually wanting to hear him speak. But he, had a very pressing indication on a matter that he had to attend in Himachal, which is his native place, and has absolutely no internet connectivity. So it was kind of his hands were tied. So the management was very kind to allow me to, present his slides on his behalf, and I thank them one more time for the same. So this is basically the talk that he was meant to give, and I'm just going to, run everybody through it. And yes, so yes, please. So this is basically going to be about AMD, age-related macular degeneration as far as the postgraduates are concerned, right? So AMD, is the leading cause of visual impairment in people over 65 years of age. Although the current definition says that it's basically anyone who has a macular neovascularization at 50 years and above would fall into the AMD group. But this is what the data says. There's no proven there's no proven prevention of advanced AMD. Even if you have, we'll actually touch upon some of the oral supplements in subsequent slides. It's a major challenge, and prevention is better than cure. We've heard that for many years. It couldn't have been more true for this disease. We're still lagging far behind as far as prevention is concerned. And after a little bit of that, very brief background, we're just going to dive into the age-old classification of AMD, which is the international classification, which says early and late AMD. So the early has drusen's, might be characterized by hyper or hypopigmentation of the fundus, and late can be either dry AMD and its late counterpart, which is geographic atrophy, or wet AMD, and we'll be coming to what other components of what wet AMD might be. So the AREDS classification is like that. So no AMD is basically no drusen or few small drusens, size that less than 63 microns, in the absence of any of the other signs of AMD, and the acuity better than that. So we're basically keen to look at early, intermediate, and advanced AMD. I think one point to take out from this classification is not any small drusen of any size. If you see it in the back of a person's eye, you can't label the person as having a early AMD, right? As is clearly mentioned in that no AMD line. So again, early AMD is less than 20 medium-sized drusens, and the size is there 124 microns, or pigmentary abnormalities, and the acuity is better than equal to 2032. Intermediate, which is where a lot of patients might come to you early, is when you have at least one large drusen greater than 125 microns, or numerous medium-sized drusens, which is the number more than 20 when drusen boundaries are indistinct, and number more than 65 if it's distinct, or there is presence of geographic atrophy, which is not involving the center of the macula, and the acuity is actually better than 2032. Advanced is again AMD, as we've seen in the previous slide. It's either geographic atrophy involving the macula, or it's the presence of a CNV, and the acuity is less than 2032. So, so this is a photo from the original AREDS classification. There are very few or no drusens. That's actually category 2, which is early AMD. So basically, this is the stage when you hardly ever, so you have pretty much normal vision. You very, very infrequently will have metamorphopsia. So this is most likely incidentally, picked up. And, obviously the patient wants to know what is the, progression rate to advanced AMD at 5 years. It's very low. It's about 2%. Again, we just talked about in the previous slide what, the early AMD subgroup is. I'm not going to go over that again. Then you get into the business end of this classification, which is the intermediate and the advanced AMD. So the intermediate AMD or the category 3, we went through what constitutes intermediate AMD and advanced AMD. So advanced AMD can be one of the two. The one on the left is a typical, you can see subretinal hemorrhage. You can see that membrane involving the fovea. That's your typical exudative or the neovascular AMD. One on the right is your geographic atrophy. There's no bleeding, but there's a kind of a moth-eaten appearance to the back of the eye, and that's because there is loss of tissue and there is atrophy. Now there are diagnostic tests in AMD. Once you've actually picked up, or clinically picked up signs that the patient has AMD, and based on your knowledge, you've actually fit the patient into the clinical classification of early, intermediate, or advanced. You actually want to go ahead and look at the different parameters and different tests that you can do, which A, will help you categorize the disease better, and B, help you in prognosticating and following the patient. So there's fundus photography. There is our Man Friday, as I like to call it, in a retina person's OPD, which is the OCT. You have the new kid on the block, which is the OCTA, which is super for this. You have fundus fluorescein angiography, you have fundus autofluorescence, and you have ICG angiography. We're just going to touch briefly upon each one of those. So this is non-neovascular AMD, which is dry AMD, which could be early, intermediate, or advanced. You typically have drusens. You have retinal pigment epithelial changes. You can have geographic atrophy. You can have varying combinations of these in the same eye. And again, geographic atrophy, as per this study, as per the AREDS classification, was diagnosed as a sharply delineated area of at least 175 microns. In which there was absence of RPE, so the underlying choroidal vasculature was actually seen better. This classification has changed a bit, and we no longer, geographic atrophy, the term hasn't gone out of use, but the newer terminology I'll be coming towards the end of this talk. Then you have wet or your neovascular AMD, which a lot of people are very, very keen to know, because that's pretty much what you can treat as of now. And there is something known as a macular neovascularization. We're all very we're all aware of CNV. We have been using the term choroidal neovascularization all our lives. But as I said, towards the end of this talk, I'll be talking about macular neovascularization and what the change in terminology is there. So again, you can have direct evidence. There is gray-green elevation with overlying serous detachments. You can see that in the photo. You can have RPE, a pigment epithelial detachment. There could be subretinal lipid, subretinal blood, or in late stages there could be just that ghastly looking lower bottom right picture, fibrosis, in which kind of the battle is lost, so you can't do too much. But all of these will tell you that there is either evidence of active, or there was active neovascular AMD in that eye at some point in time. That's the fundus photo. The optical coherence tomogram, and you have various types of it. These are some photos from when Dr. Dogra, I think, started doing this 2010s. And 11s. This is actually from the time domain thing. You can actually see that the one on top shows a membrane with intraretinal and subretinal fluid, and the bottom photo shows that that's not a macular hole. That's actually looks like a macular hole or a type 2 closure in the macular hole, but that's actually geographic atrophy. Once you correlate it with the photo, with the sharply demarcated borders and the underlying choroidal vessels visible there. This is a different kind of a photo. This is a pseudo color taken on an IDON, and just an example of what the OCTA, the optical coherence tomography angiography, which I feel is excellent to not only diagnose these patients but also to follow them up along with OCT. So that's the kind of membrane that you can see, the bottom left, the photo. So that's the kind of membrane that you can see when there is absolutely no, very, very minimal exudation. You can see just a little bit of subretinal fluid on that OCT, and the pseudo color posterior pole photo looks fairly innocuous. So there's that big membrane and needs treatment, and the OCTA will actually show it and help you plan therapy and also convince the patient that treatment is required. And then we come back to fundus fluorescein angiogram, our old workhorse, which quite frankly, a lot of people don't do nowadays for diagnosing neovascular AMD, right? The era of the classic and the occult membranes and the minimally classic or, minimally occult and, planning whatever treatment is now, way in the past. But, that's what you see when you do, a FFA there. This is autofluorescence. I'm not going to touch on the FFA now. As I said, I'll be coming to that later on after we come to some of the newer classifications of that, and then look at what the FFA might tell us. That's the autofluorescence, and it's basically can be used in a lot of different scenarios in AMD, but it's basically there to demonstrate geographic atrophy, because the RPE, because the autofluorescence comes from the fluorophores, in the retinal pigment epithelium, the lipofuscin. So if the RPE is gone, the autofluorescent signal is gone considerably. So that black patch, the black blob, black blob on the left and the multiple black blobs on the right show that there is loss of RPE in that area, suggestive of geographic atrophy. So it can help to monitor either progress or no progress. And there are different patterns of autofluorescence, which is beyond the scope of this lecture. But if anyone's interested, there are different patterns of geographic atrophy on autofluorescence, which can predict the rate of progress of geographic atrophy over 2, 5, and in fact, even over 10 years. But as I said, if anyone wants to read that, they can go through, that publication. This is ICG, right? And us being Indians, part of Asia, we see more than our fair share of polypoidal disease. Again, we'll be coming to what that is in the newer classification. It'll actually show you as it's showing there. It'll better highlight the choroidal vasculature, so you'll be able to see choroidal detail better, and if there are aneurysmal outpouchings. So polyps is kind of a term which is, I think, on its way out. The consensus nomenclature later says that polyps might not be the best term to use, although we still call it polypoidal choroidal vasculopathy. So aneurysmal dilatation, and you can see that fuzzy network of vessels, which is the branching vascular network. It's just another tool which helps you see better. Also, if there's a thin subretinal hemorrhage, it'll also ensure that the longer wavelengths used for ICG will be able to penetrate it better, and you will give you more objective evidence of what's going on. You have certain risk factors for AMD. Most of them are non-modifiable other than smoking. So aging, you can't reverse aging. I wish we all could. If there's a family history, you can't unfriend or change your family history. Caucasian race, although the jury on that is now out, because a lot of the initial data on AMD came from the Caucasians. But with PCV and other things happening with us, although our incidence of AMD is lower, but again, the jury on that is still out. In 10 years down the line, this might not be true. Hypertension again, but smoking is something which I think its emphasis cannot be underestimated. The emphasis on stopping smoking in a patient with either a family history of AMD, loss of vision in one eye because of AMD, or intermediate AMD in either eye. Then once you come to management of dry AMD, then you have certain manage modifiable risk factors, and I talked about smoking. The rest you can't do too much about because they're non-modifiable. And you also have the oral supplements, which is forms one of the two things that you can do for these people. One are the oral supplements, the other are the injections. We come to the oral supplements, or the IREDs. And here are the modifiable risk factor. We just talked about smoking. Environmental factors, again, jury on that still out. Dietary habits, again, if you were to look at all of these. So, this is what you want to do. Keep your BP low, stop smoking, lesser or little saturated fat, fat or trans fat, decrease salt. Salt has more to do with hypertension. Again, fish oils, basically to increase omega-3 in your diet. You could just choose to pop a couple of pills of omega-3 if you can't do that. Have a lot of green leafy vegetables, organic sources. So a lot of what is written here might be recommended for just a healthy life in general, right? But stopping smoking, getting your BP under control, and omega-3 is something that you have decent evidence for. The rest, well, there's no harm in trying. Again, the AREDS conclusions are right there. So patients older than 55 years should have a dilated exam to look at the fundus to determine their risk of developing AMD. And this is across the board. And you must understand, these are Caucasian guidelines. They have a smaller population and a higher incidence as of now of AMD. So those with extensive intermediate size drusen at least one large drusen and non-central geographic atrophy in one or both eyes, or advanced AMD or vision loss due to AMD in one eye, and without contraindications such as smoking, should consider taking a supplement of antioxidants. So basically, if you have intermediate AMD or advanced AMD in one eye, or you have intermediate AMD with a very strong family history, is something that, and you are either you don't smoke, you've never smoked, and there's no history of lung cancer in your family, then you're a good candidate to be put on oral supplements, which are the antioxidants. And what do? Right? They reduce the chance of severe vision loss, or they reduce the chance of you going on to developing advanced AMD by 25%. So if 100 people with intermediate AMD were to progress on to advanced AMD, and all of them were put on these oral antioxidants, 75 would still go on to develop, advanced AMD, 25 would not. But a 1 out of 4 chance for a lifelong illness is a chance, I think, which is worth taking. Even if you can reduce it by 25%, I think it's something that that should be offered, provided it's not been given to a smoker, it's not given in early AMD or in no AMD, and with just one small drusen in one eye. Again, so the progression in AMD is like this. We're not coming to the business end, the injection part, and then just ending. So a recent Cochrane systematic review concluded that antioxidant vitamins plus zinc probably, and the word is probably, slows the progression to late AMD and vision loss. And there is moderate certainty of evidence. I told you we don't have level 1 evidence. There's no randomized RCT to say, because there are lots of variation, lots of factors involved. And for a disease which is multifactorial, it'll be very difficult to look at just one oral supplement, and we'll never have level 1 evidence, according to me. But this is the Cochrane database review, which is as close to good quality evidence as we'll get. They also concluded that supplements containing only lutein and zeaxanthin may have little or no effect on the progression of AMD, which is in stark contrast to what we had earlier. So yeah, so now I'm just going to touch a bit on the newer classification, some of the newer terminologies which were there, which are very, very recent as far as. So this I think this is the citation at the bottom of this slide. So this is actually May this year, and all of the imaging experts of the Macula Society got together and had a consensus meeting, and they took out this paper which had consensus nomenclature for reporting neovascular AMD, and they introduced a term which was MNV. So we're very used to using the term choroidal neovascularization. However, they said that MNV denotes neovascular disease in the macula from any cause. If it happens in a person over 50 years of age, it is MNV due to AMD. And why they discourage the use of CNV is that because in AMD, the neovascularization may either start from the choroid or start from the retina. And if you're using the term CNV, it signifies that it can only start from the choroid. Hence, they now strongly recommend that you use the term MNV, or macular neovascularization. And the types of MNV, and this pretty much is the crux of your neovascular AMD and what it is. There is also another citation at the bottom of this, the number 2 on this slide, which is even more recent, just came out this month. Early this month, and a shout out to the Asia Pacific retina specialist. They got together and took out consensus nomenclature for polypoidal choroidal vasculopathy, and also took out diagnostic criteria for polypoidal choroidal vasculopathy to diagnose PCV in the absence of ICG, which a lot of people don't have access to. So that is one article I would really suggest a lot of the PGs to get their hands on. They have a couple of tables in that which sums up pretty much a lot of things that I'm talking about. So if you have a type 1 MNV, as I said, the macular neovascularization, that means what was earlier called in the FFA era as an occult CNV. It basically tells you that the choroid is the source of new vessels, and those new vessels are confined below the RPE. If you have a type 2 MNV, which was earlier called as a classic CNV, it shows that, again, the choroid is the source of the vessels. They were in the sub-RPE space. They have now breached through the RPE and now are lying in the subretinal space. There is a variation, as per them, of the type 1 MNV, which is the polypoidal choroidal vasculopathy, seen much more commonly in Asians. It is a variant of type 1. It has a lot of other differences, but basically it has aneurysmal dilatations and a branching neovascular network in addition to that. So it is also called by some people as an aneurysmal type 1 MNV. You also have a type 3 MNV, which was earlier called the RAP, or the retinal angiomatous proliferation, by Dr. Gass. It basically says that the source of the abnormal vasculature is the retina, and those vessels from the retina go down into the choroid. So you can have type 1 MNV, type 2 MNV, type 3 MNV, and the type 1 MNV can have an aneurysmal component, which is the polypoidal choroidal vasculopathy. So now, if some of the details, I have not gone into that, because if you were just to go into those, nomenclatures, it's quite exhaustive list, but it's an excellent article to go through. And I would, recommend that to most people, especially the postgraduates who've actually looking at this webinar. So, I mean, so again, you have laser photocoagulation. If you were to write a theory answer, you might have laser photocoagulation, anti-VEGF, PDT, combination therapy. Laser photocoagulation, in the macular photocoagulation study was there. Hardly anyone does it. It does have a role for extrafoveal leaks. It's generally done for non-AMD related CNVs. Very, very, very seldom done for this. It does have a role in, PCV if it's extrafoveal, but we'll come to that later on. So, the management is anti-VEGF, and you can have a million permutations, combinations on that. The Marina and Anchor trials, I'm not going to go into them for the paucity of time, but these are landmark, and you must know what they showed. And they, for the first time, showed that anti-VEGFs, outperform anything else that you might do. And there's actually visual acuity improvement, which is possible. And then you have the CAT trial. The CAT trial, which was actually a head-to-head comparison in which they compared two of the at that point in time commercially available anti-VEGFs, and again which continue to be the most commonly used anti-VEGFs globally, which is bevacizumab and ranibizumab. And they kind of said that you can use the cheaper alternative and it works fairly fine at 2 years, right? There's not too much of a difference. The patient's not going to stand to lose too much. Then you have aflibercept, which is a kind of a relatively newer entrant into the armamentarium. You have the View 1, View 2 studies. We just heard Dr. Preetam Samant, talk about ILIA, mention about it briefly. I'm not going to go into, what its molecular structure is and, what it does. It basically, at least theoretically, and in some cases, after the first 3 loading doses, it does offer a longer treatment-free interval to patients, although at an added cost. So again, this is some data on what their structures are. I'm just going to skip over that. So this is basically the current practice of anti-VEGF therapy. This is a topic in itself, but just to kind of try to sum it up. So your monthly injections for the first 3 months, followed by an individualized maintenance therapy. So you can go through down one of 3 roads. Either just keep injecting monthly till the cows come home. Either the patient gets sick and tired of you, or you get sick and tired of injecting. You just keep injecting monthly. A lot of people, in the West do that, where you can track your patients. You can actually call your patients if they miss an appointment, and just irrespective of whatever, you just keep treating monthly. That's A, very costly, and B, also very cumbersome to come back in every month. The second is you treat monthly for the first 3 months, the loading phase, and then you can do a PRN or you can do a treat and extend. So Dr. Preetam Samant actually made my job easier, and he spelled out treat and extend for DME very well. The treat and extend for AMD is similar, although the number of injections required is much more. A PRN, a modified treat and extend, and a modified PRN is what most of us do. So you give 3 loading doses, and then you might choose to inject as and when, if the vision goes down or fluid appears. That's the PRN. A treat and extend, as Dr. Samant said, is again you treat, and then if everything's okay, you extend the interval, then you treat again, then you try and extend the interval, and you find the optimum extended interval at which the patient needs to come in, which might be for some people 2 months, for some people 6 weeks, for some people 12 weeks. So again, so when you follow these people up, so when you're following them up, I think FFA has no role, fundus photo a little bit, but OCT and OCTA, A, if you want to, A, diagnose, and B, follow them up. So on the OCT, you want to look at increase in central retinal thickness. You want to look at whether there's fluid, and whether the fluid is in the intraretinal space, subretinal space, or sub-RPE. If there's any fresh hemorrhage, you'll be able to pick that up clinically. Patient has visual symptoms, or there's a change in OCTA, in the membrane size or the branching pattern. And all of those might be... sorry, my slides seem to have frozen. Sorry, is my screen still visible?
Yeah, screen is visible, but it's not moving.
Yeah.
Post-treatment follow-up. Yeah.
Yes, it's not moving. So I'm just going to, yeah. So I had 7 more slides, and they were basically to show one patient of, so they were basically examples. And I'm sorry why, I think my computer's kind of frozen there. So I apologize for that. I'm just going to be just going to take a couple of minutes and just try and conclude and just tell you what the rest of the 7 slides were. They were basically treatment examples showing OCT or at presentation, OCTA at presentation of patients with type 1 MNV, type 2 MNV, and PCV, and what the role of verteporfin and PDT might be, and how do you combine it with either Lucentis, or you can just choose to treat with Eylea for a PCV. So I mean, if I were to just conclude, so just I think from the PG viewpoint, if there are 5-6 broad topics, AMD is a very big thing. If there are just 5-6 broad topics that one can look at, one is one must know about the ARED studies, the AREDs 1 and the 2, and including the supplements. I haven't gone into what the different supplements contain, what the dosage is, although you must know what the role of why do you don't want smokers in that? What's the role of zinc? What's the role of copper? So you want to know a lot about the ARED study. You want to know a lot about the classification, the no AMD, early, intermediate, advanced. You also should know about the recent nomenclature, because MNV, what is type 1, 2, 3, RAP, and although it'll take about 4 or 5 years for people to switch over to using those terms, and RAP will continue to be type 3 MNV, but I think one must be aware of the PCV guidelines, the ICG characteristics of PCV, OCT characteristics of PCV, and I would have shown had this moved forward. I'm sorry, and also that paper which I had quoted, which tells you how to diagnose PCV if you don't have ICG, and a lot of people might not have good quality access to ICG. As far as treatment is concerned, I think there are n number of trials, and yes, some of the trials like Anchor, Marina, Pronto are something you should know something about. You should also know some data on the CAT trial, the newer studies, the View 1, View 2, the Everest, the Planet, a lot of data on that. But I think in general, what you must know is that for PCV, PDT still has a role. You have different components in PCV. Monotherapy with Eylea might work very well, but monotherapy with Lucentis is not the best available treatment option as of now. And as far as treating geographic atrophy is concerned, there are certain newer drugs on the block, and they aren't commercially available as yet, but we are hopeful that they would be. And I'm very certain in the next half a decade we will have a treatment for at least preventing progression of geographic atrophy. So I apologize again for my slides kind of freezing at the last moment, and I thank everyone for their patient listening. Thank you.
Thank you, Dr. Mohit. Thank you for accepting in a short notice and presenting instead of Dr. Mangar. Thank you so much. There's a small swap. Dr. Sushma has got another presentation, so she's going to go first. Let me introduce Dr. Sushma. She has finished her fellowship in comprehensive ophthalmology from LBPI. She underwent training for glaucoma at Mayo Clinic, Rochester, USA. And her area of expertise are glaucoma surgeries, including glaucoma shunts, pediatric glaucoma management, and refractive cataract surgeries. She has presented at several national and international meetings, has multiple publications in peer-reviewed journals, and also written few ophthalmology book chapters. She's presently working as a consultant and head of glaucoma services at Narayan Netralia. We welcome you, ma'am, to talk to us on glaucoma workup today.
Thanks, Dr. Saundari, and I'm grateful to Dr. Agarwal and Kalpavriksha team for having me on such a wonderful platform. And thanks to Dr. Swati also for last minute swap as I had to leave for another webinar. Thank you so much. So I'm going to talk about glaucoma workup, although I'll just brief on that because it's a very short thing to talk about. A longer thing, I would say. It's a basic thing, but it is very, very important. Are you able to see my slides?
Yes, ma'am.
Okay. So, right. So as we define glaucoma, we largely talk about a chronic progressive optic neuropathy and a corresponding visual field defect. Intraocular pressure is considered a major risk factor, but is not important for the diagnosis. Largely, glaucoma diagnosis revolves around changes and field defects. And gonioscopy does play an important role to diagnose the type of glaucoma. So these are the 4 basic things that we need for any diagnosis of any glaucoma patient and planning the management. Now, important thing is that we have to be unbiased while collecting each clinical finding, and then we have to interpret these findings in correspondence to each other. And we also need to appreciate these findings because these are sort of a continuous variable, so we need to understand there can be normal variations. So as far as intraocular pressure is concerned, I'm sure all of you are familiar with all these instruments that we use for checking intraocular pressure, but most important being Goldman applanation tonometer. So this is the standard of care when we check intraocular pressure, and there are situations where we use other tonometers. I'll not go in that detail right now. Well, what is the role of intraocular pressure? As I said that it is a major risk factor. We need to understand what is normal. When we are talking about normal, we are looking at 2 standard deviations away from the mean in a normal population. So that is what we consider as normal, because there's more likely of this particular range to be normal for a given patient. Now, any absolute value of IOP is not diagnostic. We need to understand the higher IOPs are associated with higher risk of glaucoma. So it is not an absolute term. And there are significant number of glaucoma patients who would have normal IOP. So normal IOP should not give us a false sense of security of no glaucoma. Now, to minimize the variability in recording of intraocular pressure, what we should do is that we can take a mean of 2 consecutive readings. And if there is a difference of more than 2, then we should take a third reading. We need to understand that we need to measure intraocular pressure at different time points. So you need to have diurnal measurements. And we also need to measure the central corneal thickness and adjust for that, as we know that CCT contributes a lot to the intraocular pressure measurement. Coming to the gonioscopy, well, this is a very, very important tool, and it's a very quick examination that you can do in the clinic, which can help you in diagnosing, treating, as well as prognosticate a particular disease. Even primary open angle glaucoma diagnosis cannot be labeled unless we do exclude PACG, that means the angle closure glaucoma, or other secondary glaucomas by doing gonioscopy. So a good gonioscopy is definitely essential. I'll just share a small video with a voiceover which tells you how you do a gonioscopy in the clinic.
Commonly used gonioscope for indirect gonioscopy is 4 mirror that has the contact surface smaller than corneal diameter, whereas this is the 2 mirror lens that has concave surface and is larger than the corneal diameter. To perform gonioscopy, position the patient appropriately on the slit lamp, examine the ocular surface, and note the condition of the optic nerve with undilated pupil. Explain the procedure to the patient and instill the topical anesthetic drop. For the 2 mirror lens, use lubricating drop as the coupling agent. Hold the upper lid, ask the patient to look down and insert the lens. Then magnification can be increased to see the angle. For the 4 mirror gonio lens, hold the lens in front of the cornea and then move closer as you make contact by keeping a watch on the tear film. Once the tear film is evenly distributed, the view of the angle is clear. First objective of performing a gonioscopy is to look at the occludability of the angle. Gonioscopy is first performed in a dark room with a small light falling on the angle so that pupil may not artificially open the angle due to light reflex. Once the angle is observed 360 degrees in this condition, the light can be increased and the slit beam can be enlarged so that the light falls on the pupil and opens up the angle. To identify angle structures, it is important to identify the Schwalbe's line, and that is done by making a thin slit beam and oblique illumination on slit lamp while performing gonioscopy. In superior or inferior mirror, one can observe collapsing of the light beam that illuminates Descemet's and Bowman's membrane. As the Schwalbe's line denotes the end of Descemet's membrane, the light no longer passes through the opaque structure beyond Descemet's and causes the collapsing of this beam. And this is called corneal wedge sign. The place where these 2 beams convert into one is the Schwalbe's line, and posterior to that are the rest of the angle structures. This angle represents the normal open angle in an individual. This particular angle shows narrow entry with only Schwalbe's line visible with the small light. However, with indentation, the angle opens up, thereby suggesting appositional closure. Here, one can see patchy pigmentation of the posterior trabecular meshwork, which is indicative of signs of prior occlusion. In certain angles, you can see goniosynechiae at one or multiple places. If the angle does not open despite indentation, that suggests synechial closure.
So, well, it is very important to make a diagnosis of primary angle closure, but so that we can decide whether we are going to go ahead with a YAC-PI or we are going to go ahead with a medical management in a given patient. However, there are certain other pictures I'm going to show you where gonioscopy can be useful. So this is a picture where you can see some pigment and here as well, which looks like a synechia. But when you indent, you can see that there is another trabecular meshwork inside. So it's actually an angle closure and this was like a pseudo angle. Whereas this was a pseudo synechia because as you indent, you can see that it opens up. So it's important to understand the technique of gonioscopy so that you can pick up findings and do not get confused. Plateau iris is another condition which can be picked up only by gonioscopy. You can see that, convex appearance close to the angle, and then there is a depression giving you a sine wave sign, and rest of the angle appears as the angle closure. So this is something that can be checked only by UBM other than gonioscopy. So gonioscopy is a very simple tool, and you may not need UBM for diagnosing a plateau iris. This is one of the example of IC syndrome. This is a black ball suggestive of old hyphema. This is how an angle recession looks like. This is a foreign body in the angle. You can see a glass foreign body there. And this is a silicone oil in the angle. So that can tell you why the patient after retina surgery has developed glaucoma. Pigment dispersion syndrome is another important thing which you can detect on UBM. However, angle tells you a very nice concave configuration of the iris and heavy pigmentation in the angle. Iris cyst can also be picked up by this kind of a bulge, and then you can confirm on UBM that this is an iris cyst behind. Cyclodialysis looks like this. So these are, this is a vitreous blocking the internal ostium so as to understand why your trabeculectomy has failed in this particular patient. So gonioscopy plays an important role. However, when you come next further, the diagnostic criteria as suggested by the EGS guidelines, you can make out the optic nerve head is the next important thing that we need to understand. So wherever you see this optic nerve head abnormal, those are largely corresponding with diagnosis of glaucoma. And then is the visual fields. So if you look at, if the optic nerve is abnormal, that is definitely glaucoma. Whereas if the visual field alone is abnormal, then we have to consider other factors irrespective of IOP being high or low. So next is the, how do you examine or do the optic nerve evaluation in glaucoma? Well, this is again a short clip. It is important for any glaucoma person to examine optic disc even in an undilated pupil, because before you do gonioscopy, you need to assess. So again, here you ensure proper positioning. Focus the cornea on retroillumination. In the bottom window, you can see where I'm focusing. Interpose the lens in front of the cornea or in front of the eye, and then pull the joystick towards you. Once you start seeing the retina or the nerve clearly, after that you should only make sideways movements to see the optic nerve in detail, or widen the beam to see the optic nerve in detail. So this is how you can pick up, and you can use the green filter to look at the RNFL defects and stuff. Well, when you have the opportunity to dilate the patient, if the angle is open, you should definitely do a dilated disc evaluation. And this is how it looks like on the slit lamp. Even in an angle closure glaucoma patient after PI, you should be doing a dilated examination. And this is how you can pick up. You can see the disc hemorrhage clearly in this. So this is something very, very important, which is a small clinical examination, but makes a lot of difference for you to diagnose optic nerve or glaucoma, because that's the primary end organ where the glaucoma affects. Okay, so there are few things that I would talk about these particular things when we examine the discs. You need to keep in mind, like these are the two discs. If you look at the upper one and the lower one, now if you look at the arrows, now this is a small disc with 0.5 CD but still abnormal disc, whereas this is a large disc with 0.7 CD but still normal. Why so? Because the disc size is different. So these are three discs of different sizes, small, medium, and large, all being normal. So that is why we need to understand that CD ratio is always in relationship with size of the disc, and on its own, it does not mean very much. So whenever you're recording a CD ratio, you should also keep in mind that whether your disc is small, medium, or large. CD asymmetry is a very important point. This is the, if you look at this, is the right eye, left eye of a patient. So you can see right eye disc is CD is higher than the left. So this becomes important, and you can see the on the perimetry also the right eye is abnormal. When you talk about the neuroretinal rim or shape or size, which is most important thing to pick up, because CD ratio is a surrogate measure, and neuroretinal rim is what we are looking at. So here also the three-dimensional checkup of the optic nerve or stereo view becomes important. So if you look at the cut section of the optic nerve, this is how a normal nerve should look like. And initially what happens is the backward bowing of the neuroretinal rim, which is called saucerization, and then sloping happens where you see the thinning of the rim or the sloping edges. And then finally, when there is loss of neuroretinal rim, you see a notch. And this is how these stages look clinically. This is an example of a large nerve where you can see almost 0.8, 0.9 cup. And if you see carefully, the inferior rim is thinner than the superior. So you're looking at ISNT rule. And if you look at the visual field, you can see there's a corresponding superior defect. The localized NFL defects are very, very specific signs of glaucoma, and they are typically dark, touching the disc, and fan out. They are very classical signs of early glaucoma, and usually correlate with your field changes. And even in pre-perimetric glaucoma, you can find these changes and confirm them by OCT as well. Disc hemorrhages, again, are not very common to be seen in glaucoma. They are common to be seen in normal tension glaucoma and early glaucoma, and they disappear over a period of time. So you do not see in large number of glaucoma patients, but when they are present, they are very, very specific for glaucoma. So presence of disc hemorrhage is important. Absence does not exclude glaucoma. Myopia is something which confuses always because myopic changes do overlap with glaucoma. So you have to be careful. Like if you look at this patient, right eye, left eye, the disc looks quite glaucomatous, but this is due to high myopia, and you can see that in the perimetry. This is just the enlargement of the blind spot that you see here, and actually it's not glaucoma. So it's important to understand that. Now, if we come to the investigations, well, visual field and optic nerve is something which is very important, and perimetry and imaging comes next after the clinical evaluation. ASOCT and UBM is only in select situations, is that what we need. Now, the WGA also recommends assessing both structure and function. So understanding perimetry and imaging is important. I will just pass through those things because it is not possible to take you through the whole perimetry, assessment and OCT assessment in a short while. But what we need to understand is what are indications of perimetry. When you have a clinical suspicion of glaucoma, or you see a patient with a high IOP and the disc is suspicious, or you have a primary angle closure. To establish the diagnosis of glaucoma, because you have to check the functional aspect, as I showed you in one of the patients, that myopic disc where the disc was appearing quite glaucomatous, but actually the function was normal because there was an overlap with myopia. If a patient comes to you with on treatment for glaucoma and there is no recent baseline functional assessment, in those situations also you need to do visual field and repeat for baseline if they are unreliable or they do not correlate with your clinical findings or disc findings. So to simplify, the printout is divided into these kind of segments, and I'm sure you have all would have read this article, IGO article. It's a very old article which clearly mentions how you should look at each zone. So zone 1 here is patient and test data. Zone 2 is reliability indices and foveal threshold, which is the first thing to look at whether patient has done the fields reliably or no, so that you can understand whether you can take this data for use. Zone 3 and 4 give you the raw data or the absolute threshold sensitivity, which is not very important in terms of, because you need the statistical comparisons. So for that you have this total deviation plot, that is zone 5, and the pattern deviation plot, which is the most important part to look at when you're looking for checking for glaucoma. That is the zone 6. Zone 7 gives you global indices. That means the whole gist of the perimetry, that how abnormal it is given in simple numbers. And glaucoma hemifield tests give you whether it is abnormal or generalized depression and things like that. So in nutshell, the normal hill of vision, if it is like this, generalized depression will have an overall sinking. A localized scotoma is what we expect in glaucoma. So that is where you will see a localized loss. And in a cataract and glaucoma or a generalized depression and localized scotoma, this is how the visual fields would look like. So this is a normal field. This is only focal defect, that is more of glaucoma. This is like generalized depression and local depression, which is more suggestive of cataract and glaucoma or refractive error or glaucoma or any other causes of generalized depression. Whereas this is not suggestive of glaucoma, and that's why I say pattern deviation plot is the most important plot that you should be looking at for glaucoma. Now, these are the optic nerves, some examples that I'm giving you. You can see there's a superior notch here, and this shows you RNFL defects, and there are corresponding perimetry changes. So that establishes the functional damage. In a situation like this, where you see a small change in these kind of a situation, but you should always correlate it clinically with the optic nerve. So giving a diagnosis on a perimetry is not a wise thing to do, because you can see this is a field defect which has come through the choroidal coloboma. This is a field defect which has come due to myopia. This is actually enlargement of blind spot and not glaucoma. Another very classical inferior arcuate scotoma, but if you look at the optic nerve, this is largely because of the vein occlusion. So it's important to have a dilated disc and fundus evaluation to correlate it with the perimetry or the functional damage. Fields alone cannot detect glaucoma, and the defect has to be correlated with the clinical findings. Now, role of imaging. Well, imaging is essential for pre-perimetric glaucoma, where you see a disc change, but you don't see a functional corresponding change. And if the patient is not able to perform fields due to certain reasons, or not able to concentrate on fields, inability to perform fields due to some reason, it is desirable for as a baseline for mild and moderate glaucoma, and even for progression of mild and moderate glaucoma. Why I have not included severe glaucoma here? Because imaging is not very useful in severe glaucoma due to floor effect, not required in advanced glaucoma. Now, just to look at an imaging printout or an OCT printout, what you need to look at is, this is the color coded thickness map, and this is the deviation map for RNFL thickness, which tells you that that is the abnormal area. This is a red-free image which can tell you whether there's any RNFL defects and all. And these are the RNF average thicknesses, where you can see the numbers and compare. And this is a RNFL thickness values in comparison with the normative database. So green is normal and red is abnormal and yellow is borderline. This is according to the testnet graph. That means open up the whole disc and put it as temporal, superior, inferior, nasal, temporal. And the next one is related to the 12 clock hour quadrant. So that can tell you that where at all is the deficiency or thinning of the RNFL in a given patient. And this, the central one, gives you the optic nerve head parameters. This graph gives you the rim disc ratio. The different printouts can appear different, but all of these components are there in largely all the OCT machines. So this is a thickness and deviation map, which can tell you, you have to correlate with them and understand that what are the abnormalities, and an optic nerve head analysis, which gives you an idea about the nerve width or the rim area, cup diameter, disc diameter, so that you can understand what are the optic nerve head analysis results. Last thing, but not the least thing, is that in addition to these things in glaucoma, we also need to give some importance to the systemic conditions in normal tension glaucoma. One thing is that we, especially when the pressure is normal and you are seeing a disc and field changes, you should have multiple readings. Even a full day DVT is something that is recommended for diagnosis. Blood flow plays an important role. So you need to have a history, good history and systemic evaluation to understand whether it is the ischemia which is causing this kind of a disc or nerve damage that you're seeing. You should keep in mind, especially normal tension glaucoma, the BP, the heart rate, the ECG, echo, etc., required to rule out the ischemic factors. In a younger patient, if you see an NTG, neurological issues have to be ruled out, and one-time ischemia is something that have to be kept in mind. We should also check for the history of sleep apnea, Raynaud phenomena kind of things, so as to understand the other risk factors and take care of them along with managing glaucoma. So to conclude, diagnosis of glaucoma is based on structure and function of the optic nerve along with the IOP, and should not be based on a single test alone. We have sophisticated test and data points, but that should not bias our clinical judgment. All test reports have to be correlating clinically, and then only we can use them for diagnosis or prognosis or even follow-up. So the gold standard for diagnosing glaucoma is a well-trained clinician. And that is why we need to integrate clinical findings with the functional anatomical damage, look at the risk factor, and then individualize our management for a given patient in glaucoma. Thank you for your kind attention.
Thank you, ma'am. That was a wonderful lecture. And I think the last slide said it all. And I think the videos that you showed us on how to perform slit lamp biomicroscopy and on gonioscopy would have been immensely beneficial to all the postgraduates. Thank you once again, ma'am. And I hope we are letting you go well in time for your next presentation.
Yes, thank you so much. It's my pleasure to be here. And I'm sorry that I have to leave early. Thank you.
Thank you, ma'am. It's my honor to introduce our next speaker, Dr. Kim. He is Chief of Vitreoretina Services at Arvind Eye Hospital, Madurai, and he has trained numerous postgraduates, DNB residents, and fellows over the last 3 decades, and I'm privileged to be one among them. Sir also has a special interest in telemedicine, and he is Director of Teleophthalmology Services at Arvind Eye Hospitals. He will be talking to us on a vast topic, macular diseases. Welcome, sir.
Thank you, Jyotsna, and thank you all for inviting me to be this most popular annual event of Kalpavriksha. I thank all the members of Agarwal Hospital, Dr. Agarwal and team for this honor. I've been given this topic of macular pathology. Macular pathology constitute a whole lot of conditions, and I've highlighted only a few of them here and have grouped them just for easy understanding based on their pathology. The first group will be the vitreomacular interface, which constitutes the macular hole and the epiretinal membrane. Macular hole, as all these students know, is one of the common conditions where there's a full thickness defect in the foveal neurosense retina and occurring in the elderly people, more commonly seen. These are about the idiopathic macular hole. We're talking about seen more commonly in the females, and there's bilaterality in about 10% of the cases. As I said, most common is the idiopathic, but you have macular hole coming up due to other conditions such as trauma, pathological myopia, even chronic retinal detachment over a period of time can develop macular holes, and of course various degenerations. The various theories that were put forward in the development of macular hole, that is the idiopathic macular hole, and the most popular is the gas vitreomacular traction theory. We will not go into it for the time constraint. But Gas also proposed the different stages of macular hole, how it develops and clinically observed. Stage 1A, you see an yellow spot in the center of the fovea with loss of foveal depression when there's a slight elevation of the macular hole edges, and there's no vitreous separation. In stage 1B, you see a yellow ring happening again because of the more elevation of the edges of this impending hole with no vitreous separation. And in stage 2, you develop a full thickness macular hole, except that this stage, the macular hole thickness or the size of the macular hole is less than 400 microns. Whereas in stage 3, there's a full thickness macular hole with more than 400 microns with no vitreous separation. As you can see, this OCT picture showing the vitreous still attached to the edge of the macular hole. In stage 4, you develop a full thickness macular hole, which is more than 400 microns in size, but there is a complete vitreous separation. You're able to see the waist ring. This OCT picture again shows how the vitreous is completely separated from this full thickness macular hole. With the development of OCT and other modalities, the classification kept changing. The International Vitreomacular Study Group have classified as vitreomacular adhesion, where there's no traction, but there's a broad adhesion or a focal adhesion of less than or more than 1,500 microns. When there is a traction or elevation on the roof of the macular hole, you call it as vitreomacular traction, again, which could be a focal or broad. But once a full thickness macular hole is formed, it's described as small, medium, or large, depending on the size of the macular hole, whether it's less than 250 or more than 250 to 400, or if it's more than 400, It could be called as large macular hole. It could be primary or secondary to various other conditions that we described earlier. The macular hole is one condition which is amenable to good surgical treatment, and there's a very good prognosis usually indicated in stage 2 and above holes, where you do a primary pars plana vitrectomy with ILM peeling and using a gas tamponade in these patients. Could be a sub6 or C3F8, and usually these patients have a relatively good prognosis or good outcome. You can see this pre-op and post-op picture of on your right, or the OCT picture where you see a grade 3 macular hole, and post-surgery it completely regains its normal architecture. In the next condition is the epiretinal membrane, also known as cellophane maculopathy. Very often it could even go unnoticed if in early stages. These membranes form over the retina as a avascular, semi-translucent fibrocellular structure, and usually it's asymptomatic, doesn't bother, but sometimes patient may become symptomatic, may present with blurred vision or metamorphopsia. Why does it happen? Very often due to a secondary to this posterior vitreous detachment, which allows the proliferation of glial cells, or also sometimes in the presence of inflammatory conditions due to the inflammatory mediators which help to form this epiretinal membrane. And if the patient is very symptomatic, surgical removal will give a good relief or a good improvement in the visual acuity. The next group is the retinochoroidal pathology. Under this, one important condition is the central serous retinopathy or central serous chorioretinopathy. Everybody sees this very often. It's a self-limiting disease of unknown etiology. There's usually a beautiful ring-like elevation that you can see when you're seeing this patient with the 90D or an indirect ophthalmoscope, and OCT clearly shows the elevation of the neurosensory detachment. When a patient, young patient or a young male patient tells you or gives you a complaint of sudden decrease in central vision with the positive scotoma, even before you look at the fundus, you can say this patient is having central serous retinopathy, and the visual acuity is marginally decreased and usually improves with a small hyperopic correction. Central serous retinopathy occurs because of the malfunction in the choriocapillaries, the choroidal hyperpermeability, and focal choroidal vascular compromise. These cause dysfunction in the overlying retinal pigment epithelium, letting this fluid get collected in the subretinal causing the subretinal sensory detachment. Very often the pathogenesis is supposedly increase in the circulating cortisol or epinephrine, and very often seen in patients who are highly anxious type A personality, in patients with who are in pregnancy, or patients have sleep disturbances like insomnia, and patients on long-term systemic corticosteroids. One of the classical investigation that is done in FFA, not in all conditions, when the patient, as I said, this is a self-limiting condition, usually it's observed, but if the vision is not improving over a period of time, 1 or 2 months, then you tend to do a fluorescein angiography, which typically shows 2 types of leak: an ink blot leak, as you can see with early, you see just an ink blot, and then with time this increases in size, indicating the point of leak, or a smokestack leak, again starting as a single point, and then over a period of time you see this typical leak happening, which shows where the leak is happening. And this also is done when you are planning to do a laser or a focal laser treatment, especially in such kind of cases where the leak is outside the foveal area. You could treat this with laser treatment. But again, there are other lasers which have come in, the micropulse, the yellow laser, and the photodynamic therapy are indicated in the management of CSR, where the leak doesn't subside by itself. The next group is the iridomacular group, which is a larger group. I've just mentioned 3 conditions here. again, because of its importance. Best disease, again, it's not very uncommon, also called as vitelliform macular dystrophy, caused by the mutations in BEST1 gene. And you can very clearly see an yellow or orange yolk-like appearance in the center of the fovea, even though vision may have good vision, and the patient typically shows this lesion, which we call as a egg yolk appearance. And in Best disease, the lesion is fortunately restricted only to the eye. It's been described how this evolves. The first stage of Best disease is the pre-vitelliform stage, where usually you may see a normal macula with a normal pigment epithelium, and the next is the vitelliform stage, where you clearly see this egg yolk appearance centered on the fovea. And third is the pseudohypopion stage, where this material is breaking down, becoming a vital eruptive stage, what they call a scrambled egg. Somebody who likes the egg changes have named this as a scrambled egg appearance due to the breakup of this vitelliform substance. And then it goes into an atrophic stage, and there's a stage 6, where if a patient develops a CNVM, he could get into a choroidal neovascular membrane at this point. So what happens in this Best disease due to a problem in the retinal pigment epithelium? There's an accumulation of lipofuscin under the RPE and raising this retinal pigment epithelium. And this, as I said, when there is a break, it can allow a CNVM to grow as a late complication in this condition. This is one condition where when somebody asks you where EOG is, electrooculograph is subnormal, you would mention the Best disease is the first condition, where the normal ordinate ratio, which is more than 1.8, is usually reduced, as in this case, which is 1.26. The management is hardly any. Usually you observe if visual acuity drops, there's a low vision aid, can be prescribed. But in case where the choroidal neovascular membrane develops, then you treat them with the anti-VEGF. Next disease, the Stargardt disease. It's usually autosomal recessive, very typical appearance of a beaten bronze metal, appearance with a fishtail or pisiform lesion surrounding the entire macular area. This happens due to a mutation in a gene called ABCA4, which again causes accumulation of this yellowish flecks in the retinal pigment epithelium. These are, when you do a fundus autofluorescence, they are quite fluorescent, and you see this central dark choroid as a typical feature in this case of Stargardt's disease. You see a foveal atrophy in OCT in these conditions. Again, the management, there is nothing significant other than observe and supportive therapy with low vision aids. The third important condition is this X-linked juvenile retinoschisis. It's a bilateral disorder occurring in males. It's an X-linked recessive condition. So you see them in males, and it's caused by a mutation in this retinoschisis gene or RS1 gene, where you clearly see the stellate spoke-like appearances with microcysts. This is a very clinically seen. You see this with the 90D or a 70 diopter lens in slit lamp biomicroscopy, and you'll be able to pick up this. Most patients are hyperopic, and sometimes these are associated with peripheral retinal schisis, usually in the inferior quadrant. And if vision is affected in early stage, these patients may have strabismus and nystagmus in the later phase. You have to remember one important pathology is the structural defect is in the Mueller cells, which holds like a bone in the skeleton in this retina. And this, when it gets affected, it loses its structure. Thereby, the retinal layers, there you see these schisis happening. Primarily in the inner nuclear and the outer plexiform layer. This is a beautiful OCT picture which depicts on your left, you're seeing this OCTA picture, NFAS OCT angiography picture taken through a outer plexiform layer of this schisis cavities that you can see in this schisis picture. Management, again, it's observation or low vision aids. When the vision drops, there's nothing much you can do. But if the patient develops a retinal detachment, due to the peripheral schisis, then the only option is to do surgery. They do well with surgery. Next group is the vascular. I won't touch upon the DME or AMD, but since it's already been covered, the cystoid macular edema is, all of us are very familiar with this condition, cystoid macular edema. You see in post-pseudophakia, in retinal vein occlusions, in diabetic conditions, in various other drug toxicities. It's a very simple clinical diagnosis, again seen with the 78 diopter or 90 diopter in slit lamp biomicroscopy. All you need to do is to treat the cause. In pseudophakia, you probably treat them with the topical NSAIDs or topical steroids. Sometimes the posterior subtenon steroids and intravitreal steroids do help in resolution. These usually have a good prognosis, especially the pseudophakic CMEs respond well with treatment. Macular telangiectasia, another very important condition, has multiple names as IJT or idiopathic juxtafoveal retinal telangiectasia, parafoveal telangiectasia, MACTEL, etc. You see, it has a very typical features. Gas again divided it into three groups. Of these three, the type 2 is the most common bilateral juxtafoveal telangiectasia, which with very minimal exudation. It is 2A or 2B. 2A is adult onset, 2B is juvenile onset, and the other two are quite rare. I'm here describing the gas description of the different stages of type 2A IJT. One is the stage 1, where there's usually you don't see a clinical abnormality, but see sometimes a late leak. Whereas in stage 2, you see this typical grayish sheen with the telangiectasia may be present. In stage 3, you see this right angle venules ending abruptly, with which you can notice in your slit lamp biomicroscopy. In stage 4, you see this RPE hyperplasia, and stage 5, you may see a development of a choroidal neovascular membrane in certain cases. The typical OCT features is very important, with and it's sometimes you may not notice the OCT clinically, but when you, the IJT clinically, but when you do an OCT, you see this inner layer cavitation, multiple cavitation. You see this ISOS disruption. This ILM drape sign may be seen in late cases. There's a centripetal pigment migration. In some advanced cases, again, you can see this choroidal neovascular membrane development or foveal atrophy can happen in these cases. The next, so the treatment again, unless this patient develops choroidal neovascular membrane, you do not treat them. There's no treatment other than observation, and again, probably if needed, some low vision aids to improve vision in these cases. CNVM, there are other non-AMD causes. I'm just touching upon the different conditions like trauma, Best disease, MACTEL, angioid streaks, in high myopia, then in CSR it could develop. In the other last two conditions that I want to talk about is the drug toxicity. There are so many drugs that are involved in causing damage to the macula, but the most important is the hydrochloroquine toxicity, where you see these atrophic paths. Sometimes you may see a normal fundus, but there's a progressive pigmentary changes leading to a bullseye maculopathy. Two important things. This is one case that we saw, yes, the bottom picture is a case which we happened to see it yesterday with a typical flying saucer sign. This happens because there's a loss of parafoveal ellipsoid zone in these cases, leading to a parafoveal thinning of the outer nuclear layer, leading to this elevation of the central area, creating this flying saucer sign. Another important investigation is this multifocal ERG changes that happens, wherein you can pick up early on the toxicity that's happening due to hydroxychloroquine, where you see a pericentral amplitude depression in these cases, leading to a central amplitude reduction and then causing a generalized function loss if not adequate steps are taken to stop this drug. Photic retinopathy, the last one, where the fundus you sometimes see is normal, but when you question the patient, it gives a history of exposure to solar eclipse or a welding arc. But when you do a OCT, you can see very clearly these outer retinal holes or a break in these cases, making you suspect these photic retinopathy. Again, there's not much that you're going to do in terms of management, but just observe this patient and give them some supportive therapy. So since there are so many conditions, I didn't have enough time in this 15 minutes to cover all these conditions in this short period of time. But just to give you a glimpse of these ocular pathologies, I thought this would be adequate enough for the postgraduates at this point of time. I again thank all of you at Agarwal for inviting me and asking me to share this topic on macular pathology. Thank you.
Thank you, Dr. Kim. That was an excellent presentation, especially those autofluorescence images, OCTA, Enphase OCT. I think the students should have enjoyed the session. Thank you again.
Thank you.
Next, we can go to the session on decision making in squint surgery. We have Dr. Swati Fulgile. She is Assistant Professor of Ophthalmology from Rajendra Prasad Center of Ophthalmic Sciences, AIMS, New Delhi. She is a winner of ARC Young Researcher Session of AOS 2006. She is also a reviewer of articles in national and international journals. And I am happy to welcome her. Thanks, Swati, for the swap with Dr. Sushma. And welcome, Swati.
Yeah, thank you, Divya. And I take this opportunity to thank Dr. Agrawal and the team for making me part of this postgraduate program. Decision making in squint surgery, I'll just start my screen share.
We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone.
I can start now, is it?
Yes. Yep.
Yeah, decision making making in squint surgery. I think squint surgery per se itself is not that complicated. The most complicated part, or I would say the most important part in squint is decision making indeed. I would, there are many factors, to when you arrive, how to operate, what to operate, how much to operate. So there are a lot of things. So I would be dealing with the basic principles whenever we are deciding about these surgeries, what principles we do keep in mind. And for the basic squints, I've tried to cover something about the advanced or the complicated squints like paralytic squints. But the presentation is mainly focused on the basic because I thought it's for postgraduate students. So I might as well stick to basics. So as I said, it is all about balancing the static and dynamic forces in squint. Now there can be various ways of balancing, but before you actually want to do a surgery, before you actually want to cut anything, you have to understand that looks in squint can be deceptive. So always rule out pseudostrabismus, and there can be many causes of pseudostrabismus like telecanthus, epicanthal fold. All this will cause pseudoesotropia. Then there can be angle kappa. If positive, will cause pseudoexo. If negative, will cause pseudoeso. Hypertelorism may again cause pseudoexo, and ptosis and lid retraction are all these pathologies can cause pseudoesotropia. So before we before we proceed to surgery, it's important that we should be sure that we are not dealing with pseudo squint. And after that, please check for amblyopia. Why I put this figure purposely, this so just to assure that it's not just enough to say and write that amblyopia treatment or patching. You have to make sure that child is patching properly. Most of the time, this is what happens. They put a patch and the child peeks through from the from the lower side of the patch or from the side. So it's important that you have to make sure that the compliance is full and child is using patching properly. After this, once you are done with amblyopia part, because amblyopia has to be treated before you operate. There are reasons why, because once you have operated, then it becomes difficult to assess which eye is deviating. And generally what happens, the eye that deviates has a poor vision. So one, it helps in checking vision, particularly in children. In adults, it's not so difficult, but in children, pre-verbal children, it's important that amblyopia is treated before we operate. Second, it also keeps parents and the child motivated. So if parents know that child has poor vision and needs treatment for that, and until that vision has improved, surgery will not be done. So parents are motivated to put that patch, motivated to continue with amblyopia therapy. Once you have operated, parents feel that now the deviation is corrected, so we do not need any further treatment. So that
really appreciative to you, Professor Natarajan, to really, building this program.
Right. Then next important step is refraction. So certain type of squints, specifically accommodative esotropias, sometimes divergent squints, can also be corrected with refractive correction alone. So as in this case, you can see that this child is perfectly aligned with glasses, but the moment we remove glasses, she is having esotropia. This is a very classical case of accommodative esotropia. So all you need to do is to give proper refractive correction and child will be perfectly okay. In this case, a case of an IDS. So if you give a proper refractive correction, the visual blur, the image blur is gone, and it promotes fusion. So once the fusion is promoted, the patient is able to align eyes. So that is also important. So therefore, it is important to give refraction before operate, check refractive error before surgery. Sometimes there is a possibility that a part of the deviation is corrected by the refraction while the other part is not corrected by the refraction. So at the end of the day, what we do, whatever is corrected by the glasses or the refractive error, that part we do not touch for surgical correction. We don't take it into consideration when we are planning for the surgery. It's only the non-accommodative part or the part of the deviation which is not corrected by the refraction is considered while taking a decision, right? So the next is also look for AV pattern. So it's not just important to look in the primary gaze and measure the deviation there, check for AV patterns. So for up gaze, you have to measure up to 25 degrees up, and for down gaze, one has to measure around 25 to 35 degrees down. There are many ways of doing it. You can ask patient to look up, or you can change patient's head posture to up gaze and down gaze so that you can do measurements. But this is very, very important, because if a horizontal squint exists with A or V pattern and we just operate for the horizontal part, the alignment is never perfect. It will definitely recur. So it's important that all those AV patterns, all those oblique overactions, I'm sure there is another talk by Dr. Rohit on assessment of squint. I think probably that's tomorrow or something, that he would be talking more about all this. But I'm just trying to give a brief view why it's important to check oblique overactions and everything, so that you can decide your surgery. If there are oblique overactions, one may have to operate upon oblique. If there are no oblique overactions, then you can leave obliques. I have examples later in the presentation. I'll be coming to it. Then also particularly in cases acquired squint, you have to investigate. Just don't jump into surgery that this patient has developed squint today and you can do surgery tomorrow. No, it's not like that. As in this particular case, you can see that there is an inferior rectus underaction here. And on CT scan, there was this large cystic sarcosis was diagnosed. So, and this is a very classical case of ischemic mononeuropathy. This patient is diabetic, and you can see that his left eye is not abducting properly. So this is a case of classical left sixth nerve palsy. This is a case of classical orbital cysticercosis leading to squint. So for acquired squints, it's particularly important that you investigate and do not jump into surgery immediately. Once you are done with your investigation, everything, do check your differentials, because your surgical management will depend on the diagnosis at the end of the day. So although this child seems to have a left sixth nerve palsy, but if you will look carefully, he also has palpebral aperture changes, which is suggestive of Duane's retraction syndrome, as opposed to the picture which is on the top, where you can clearly see that there is a limitation of abduction. So this is a case of sixth nerve palsy. However, this is a case of DRS. So you have to be very, very sure about your differentials, because management will entirely change if you have sixth nerve palsy versus DRS. Then next, coming to the actual decision making, now we have multiple options. You have on one side the strengthening procedures like resection plication, which is used nowadays very commonly. And on other side, you have weakening procedures like recessions, which is the most common type of weakening procedure we use. Then myotomies, sternotomies, stenectomies, or anti-positionings, particularly in obliques. So what are the key points when you are deciding for the surgery? Number one, recessions are generally more effective than resection. So if you have to operate only on one muscle, it's important that we do recessions than resection. Number two, medial rectus is more effective than lateral rectus. So if you look at this nomogram, 1 millimeter of medial rectus recession gives you around 3 to 4.5 prism diopter of effect or correction. On other side, lateral rectus recession 1 millimeter will give you around 2.5 to 3 prism diopter correction. Similarly, for resection, as I've already said, that the resections are little less effective than recessions. So you have little less effect as compared to recessions. But this is not sacrosanct. It varies with age, it varies with axial length, it varies from patient to patient. But these are the general principles that we follow when we decide for the amount of correction we need to do. Then the other important thing is that whether you should combine recession, resection in one eye, or you should do bilateral recessions in otherwise. So it has been seen that recession, resection, if done in one eye, gives additional correction of 25%. So for example, if you have to correct for say around 40 prisms, so rather than planning your surgery for entire 40 prisms, it's important that we plan surgery say around 30 prisms or so. Okay, so you have to divide your surgeries, whether you want to do recession, resection, bilateral recession. So if you are doing recession, resection, then you need not plan for the entire amount of the division, but you will reduce it 25% and then plan for your surgery. So that's one thing you have to keep in mind. Then as I said, there is a maximum limit and the minimum limit for recession and resection both. If you do less than minimum, it will be ineffective. If you do more than maximum, then there will be other problems. Like underaction, if the muscle is cut more than whatever is the maximum limit, then you will have underaction of that muscle. If it is resected more, then you have other problems like retraction. So you have to be careful about all this. Now there are certain muscles, which will, when you are dealing with this, there are certain things that has to be kept in mind. Like when you are operating on LR, you have to be sure that you don't take inferior oblique in your hook. What happens, inferior oblique is very closely related to LR. So it just lies beneath the LR. So the moment we try to hook LR, there is a possibility that inferior oblique can also be hooked. So it can cause inferior oblique inclusion syndrome. That has to be kept in mind. Similarly, when we are dealing with SR, when we try to hook SR, the superior oblique is very closely related to it. So there is a possibility that may come in your hook. So all these things have to be kept in mind. Then coming to weakening procedures, we have graded recession, which is more commonly used for recti muscle, right? For oblique muscle, what is commonly used again for inferior oblique, yes, graded recession as well as anterior positioning is used. For superior oblique, not free tenectomy, because tenectomy nowadays is kind of obsolete. I understand many centers in India are also following it. Many strabismus surgeons do tenectomy also. But we generally don't prefer doing free tenectomy. Either we do a posterior tenectomy or we will do a translational recession or loop surgeries or expanders as far as superior oblique is concerned. As far as inferior oblique is concerned, marginal myotomies are done. In fact, free myotomies have also been done. But whatever is preferable is graded recession again and anterior positioning. Now, graded resection is much more common with recti muscle. It can be modified. You can do a hangback where you can leave a part of suture instead of leave a part of suture hanging. Then you can do an adjustable recession or a slanting recession. So these are the maximum, minimum, and the maximum limit for recessions for all recti muscles. So for medial rectus, you have to do a minimum recession of 2.5, and you cannot recess, more than 6 millimeter. For lateral rectus recession, the minimum limit is 4 and maximum is 8 to 9. For superior rectus, it is 2.5 to 3 and maximum is 5, and similarly for inferior rectus. So it's important that we keep all these limits in mind when you are planning for surgery. What will happen if we do excessive recession? One, there can be a palpebral aperture changes especially for a horizontal muscle. So when you do more than a required recession, the palpebral aperture widens on that side. Then for inferior rectus, you can have lower lid ptosis. For superior rectus, you can have upper lid retraction. And at the same time, there can be underaction of the muscle if you excessively weaken it. So it's important that we do not cross that maximum limit of recession. Coming to the strengthening procedures, we again have graded resection. So you can decide how much millimeter of resection you want to do, whether it's 4 millimeter, 6 millimeter, or 8 millimeter. Again, it is very commonly used for recti muscle. For oblique muscles, we do not generally do resections. The technique that is getting more and more popular nowadays is plication. So instead of actually cutting the muscle, you just have to fold it. It's also known as tucking or double breasting. So you fold over the muscle on itself. That gives us that also decreases the effective length of the muscle, and the resection effect is also achieved. For paralytic squint, because the muscle action itself is very poor, so if you cut the poor or if you resect the poor muscle, weak muscle, the effect will not be that strong. So in such cases, you may do a transposition surgeries where you can transpose the muscle, one recti muscle onto the other recti muscle. It's very common for 6 nerve. We all know vertical recti Hemelschen procedures where we can transfer the vertical recti to the lateral rectus. That's also used for DRS also, or for 6 nerve where we transfer superior rectus to the lateral rectus. Single recti transposition is also being done. Then lateral rectus to medial rectus has also been done for third nerve palsies. So for paralytic squints, if you don't have the enough muscle strength, it's better to do a transposition procedure rather than doing a resection procedure or a plication procedure. Then these are the limits for resection surgery. So minimal resection, what you need to do for medial rectus is around 4 mm, while the maximum is 6 mm. So more or less, it is similar to what we have seen for recession. So more or less, the resection limits are same as that for resections. So this is a gross nomogram for the primary surgery for the very basic, simple horizontal surgeries. So what happens, whenever we have small amount of squints, say for example, 25 to 30 prisms, bilateral muscle recession is the preferred surgery of choice, particularly also in children. Why? Because under GA, it's very easy to do a bilateral recessions. While under LA, it may be very tedious to block both the eyes at the same time. Moreover, patient may also not be willing to, get operated in both the eyes. So in such cases, unilateral resections can be done. So for this is a nomogram. You need not learn it by heart. You can devise your own. Once you will start operating, you will get your own results. So surgeon factor also comes into picture. I have spoken about it in my presentation further. So surgeon factors also come into picture whenever we are deciding. But once this is the basic, which we follow for our patients, and we have learned to adjust our own surgeries according to the results that we have got. So It's important that whenever you are operating, it's important that you go see your own patients, see how they have done, so how much have you planned and how much correction you have got, so that you get the your own surgical results, and you can further plan or fine tune your surgery according to it. Then, as I was saying, that when to decide when to do bilateral recessions versus unilateral recession resection. So when you have a small amount of squints, around 15 to 30 prisms, bilateral recession is the preferred way of correcting the squint. If you have more amount of deviation, more than 30, more than 35, as I said, why it is important to do unilateral recession dissection? Because it gives you an additional 25% of effect. So for largest amount of deviation, you can choose to do unilateral resection. The bilateral recession is definitely has less operative bleeding, because resections is a little traumatic surgery. You have to cut the muscle and then the muscle bleeds. So in that way, yes, it has less recessions. Bilateral recession has less bleeding. Then, according to patient comfort, if we look at it, if you do a bilateral surgery, then it will be a bilateral comfort. If you do a unilateral surgery, it will be a unilateral comfort. Then less chances of noticeable and if you are doing MR recession 4 if you are doing MR recession in both the eyes, you are instead, if you do a unilateral resection surgery, then what will happen that you are doing one eye you are operating upon, so you are kind of creating incompetence. So that possibility is there. So palpebral aperture changes and other things are more noticeable if you do a unilateral surgeries. So other important thing that we need to keep in mind is not to induce incompetence, as I've just spoken to it. So you have to do a symmetrical surgeries or symmetrizing surgeries. What I mean by symmetrizing surgeries is that when you are operating, for example, you are correcting for a 40 prism exo, so you should not operate both MR and LR at the same amount. So it should not be that 5 mm of LR and 5 mm of MR. No, that will cause, because as we know, MR is more effective than LR. So a less mm of MR versus a more of LR resection has to be done. Okay, so for 40 prism, if we look at it, we will do 5 millimeter of MR recession and around 7 millimeter of LR resection. So this is what is symmetrizing surgery. If you do both in the same amount, there will be a palpebral aperture. For example, if you have one, there will be improper alignment. Two, there will be a palpebral aperture problem. Then there will also be a problem with because you have weakened the MR more, so MR may have more underaction. So all these things can be there. So if you do recessions in larger amount, then you can have underactions, palpebral aperture changes. As in this particular case, you can see that the right eye unilateral left eye unilateral resection was done, and you can see that the palpebral aperture in left eye is slightly narrow as compared to the right eye. So in such cases, a symmetrizing surgery or a symmetrical surgeries in both the eyes is what is warranted. Then be consistent. So it's important that you go look back at your results and be consistent. So what you are planning for 40 prisms at one point of time, you should continue with that unless you have got results which are very drastically different from what you have planned. So you can change your surgical plan according to the results that you have got, but you need to be consistent. So as I said, for 40 prisms, 5 and 7 should be enough. So for next time when you do a 40 prism surgery, you should stick with the same nomogram. But you definitely need to fine tune it according to your own surgical results. Then what are the factors that affect the outcome? So there are multiple factors. Number one is patient factor. So younger the age, more is the effect. So if you are operating on, say, a child who is less than 1 year or 2 years of old, you may have to decrease your amount of recession and dissection both. Then various patients may have various tendency of scarring. So some patients have very high tendency for scarring. In those patients, you may not get good surgical results. So the first surgery, if you know that the first surgery has failed, there are chances that likely chances that the second surgery may also not give you that kind of results. So you have to be prepared for that kind of thing. So it's important to counsel patients accordingly. Then there can be anatomic variations like axial length changes. So more is the axial length, less is the effect. Less is the axial length, more is the effect. So hypermetropic tend to have better results as compared to myopic. Then history of previous surgeries. So if there is a previous surgery, there will be scarring and your results may not be effective. Sometimes you may not be able to trace the muscle also. So you may have to operate on the other eye. Then larger the deviation, more the response. What I mean by that, as I've told that per millimeter of MR recession will give you say around 3.5 to 4.5 prism diopter of correction. So this is not a linear relationship. It is an exponential relationship. So as you increase the amount of recession, the amount of effect also increases. So what you get for first 1 millimeter of correction, you may not get it for the last 1 millimeter. You will get it more. So so you have to plan accordingly. So therefore 5 millimeter of correction will give 5 millimeter of recession will give you more correction as compared to the first 3 millimeter of recessions. Okay. Then sensory state of the patient. So if you have a patient who has good binocular vision, you have to align them perfectly, and you know that patient's fusion itself will take care of the alignment. But if you have a patient who does not have any binocularity, then you may have to overcorrect, because patients who do not have binocularity may tend to recur. So in these cases, you may need to overcorrect. Then your surgical plan also, there are certain conditions like in intermittent divergent squint where you tend to overcorrect, where you want to overcorrect, because these are the squint that tend to recur. There is a possibility of exodrift, so you want to overcorrect. So if you want to overcorrect, then you have to plan accordingly. Then there are certain conditions like accommodative esotropias where you want to undercorrect, so you have to plan accordingly. Then as I said, discussed earlier, bilateral surgeries. Then surgeon factors. This is what I was talking about when I was saying that surgeon factors do play very important role in fine tuning the surgeries. So how you place the sutures, how you take the mark, how you expose the muscle, how much dissection do you do, whether do you cut the muscular septum, check ligaments. All these things have to be taken into consideration. So as a beginner, you have to see, you have to be very careful when you are dealing with that intermuscular septum and check ligaments. And if you do more dissection, there is possibility of more scarring. So all these things have to kept in mind whenever you have planning for your surgeries, and these are the things that will affect your final outcome. Then timing. So timing is also one important thing. So for esotropias, if it is an infantile esotropia, it's important that we operate within 4 to 6 months, because we just don't want to achieve alignment. We also want to achieve binocularity. So as we all know, the binocularity starts developing at the age of 4 to 6 months. So it's important that we align patient during that time. Now, if it's esotropia with amblyopia, then as I said earlier also, that first it's important to give the amblyopia therapy, correct the amblyopia, and then operate for the squint. If it's manifest exotropia, you again want to operate as soon as possible. If it's intermittent exotropia, then these are the indications for surgery. You have to see for how much time the patient is manifesting, whether it's for more than 50% of hours or not. Then if it's Newcastle score, this is a scoring available. You can read in the books also, available on net also. So if it's more than 4, then you may have to operate them. Then worsening of stereoacuity. So for intermittent divergent squints, it's important that we check for stereoacuity. So if you have a patient on follow-up who is constantly showing worsening of stereoacuity, especially for distance, then you need to operate on them earlier. If near stereoacuity is already affected, then you know that this patient has already lost his distance binocularity, then you need to operate them on immediately. So these are the factors you need to keep in mind whenever you are timing your surgery. Then these are certain example, as I said, in this patient, as you can see that without glasses, this patient has a squint of around 45 prisms. With glasses, his 15 prisms has corrected, and now he has a squint of around 30 prisms. So when you will do your final planning, you are not going to correct him for 45, you are actually going to correct him for 30. So in this particular patient, this is the same patient. You can see that along with the exotropia, he also has binocular inferior oblique overactions. I'm sure it's visible there, this binocular inferior oblique. So you just need not correct horizontal squint. You also need to correct for this V pattern. You can see that it is a V pattern. So what we will plan? We'll plan something bilateral MR recession for 30 prism, which should be around 4.5 mm of MR recession. Then also bilateral inferior oblique weakening, which may be around 10 mm or so, or maybe more, depending on the amount of inferior oblique overaction. And this is what we get. So if you see at this patient now post-operatively, you know that he's perfectly corrected with glasses. Why? Because we have corrected only the part which is a residual after wearing the glasses. So the moment patient will remove glasses, he will show residual deviation. So it's important to counsel patient as well as parent about this thing. So sometimes parents may come back complaining that whenever we remove glasses, the patient shows squint, the child shows squint. So you have to counsel them pre-operatively that this is going to happen and we are going to correct only for the part which is not corrected with the glasses. Then for sensory deviation, as I was saying that you need to overcorrect because these are the deviation which can recur. So one needs to overcorrect, and you need to choose the surgery on the non-dominating eye. So in this case, the right eye was the non-dominating eye, and he had around exotropia of around 40 prism diopter. So we chose to do right eye LR resection around 7 mm and right eye MR resection around 5 mm. Then if you have scope of fusion, mild overcorrection, particularly in intermittent divergent squint, will help you. So in this case, we have, as you can compare for this 40 prisms, we had done 7 and 5, but for IDS, we have chosen to do a slight overcorrection by 0.5 millimeter or so. So for IDS, because of the known exodrift, we need to overcorrect. Then this is what I wanted to emphasize as far as the paralytic squints are concerned. So this is a case of LR palsy, left eye. So in this case, you can notice that the abduction is full. So you know that there is a good muscle strength. So instead of doing transposition procedure, you would like to do a recession dissection procedure, which may be supramaximal. Why? Because it's a paralytic squint. So even if the muscle strength is there, it is definitely less than normal. So you may choose to do a supramaximal. These are the amount for the supramaximal surgeries, but these are very specialized cases. We don't do this amount in regular during our regular planning. For paralytic squint, for certain other types of squint, only for nystagmus, only we choose this kind of amount of surgery. Then in this case, as you can see, this is a case of left traumatic sixth nerve palsy. There is a severe deficit of abduction. So in this case, if you plan to do a dissection, you may not get good result. So what we need to do, instead need to do a transposition surgery. So what we did an MR recession, but
Swati?
instead of doing yes.
We are running short of time. Can you?
I have just one or two more slides.
Okay.
Yeah, right. So instead of doing a full tendon transposition, we have chosen to do a half muscle width transposition to avoid ocular ischemic syndrome. Then important also to understand when not to operate. As I said, it's in paralytic squint, just don't jump into surgeries. It's important that we wait for the stabilization of deviation. As you can see, this particular patient had third nerve palsy, which over the time has got corrected. So ischemic mononeuropathies, particularly sometimes traumatic paralytic squints, do get corrected over the time. So you need to wait till 6 months of the stabilization of the deviation. So although there are a lot of options, there can be confusion about the management, but the most important key for decision is a good workup. You don't miss on pseudostrabismus, don't miss on your oblique overaction, check for AV patterns, be sure of our diagnosis, and give realistic expectation to the patients before you plan for your surgery. With that, I think I would like to thank the Dr. Agrawal and the team for inviting me, and thank you for your attention.
Thank you, Dr. Swati, for making the most difficult topic look so simple. Thank you so much.
Right. Thank you.
Now we call upon Dr. Sirisha Sendil. She is a university rank holder during her post-graduation. She has finished her FRCS in ophthalmology from Edinburgh and then did a fellowship in glaucoma at LBPI. She is an investigator for several studies, has published scientific papers in peer-reviewed journals, and co-authored a book, Clinical Ophthalmology Made Easy. She has presented over 60 papers at national and international forums. She received the Best Scientific Paper Award at the Glaucoma Society meeting in 2007 and then 2012 and 2013, and you can continue to say so many years. She specializes in managing refractive adults and pediatric glaucomas. Her other areas of interest are glaucoma drainage implants and managing combined cataract and glaucoma. We welcome you, Dr. Sirisha Sendil, to talk to us on medical management and glaucoma.
Yeah. Thank you for the invitation. So I'll move to the topic straight. We know that glaucoma is a chronic progressive optic neuropathy, and the loss here is irreversible, and we know intraocular pressure is the most important risk factor. While pathogenesis of glaucoma may include mechanical factors, vascular factors, and biochemical factors, what we know is currently the treatment options that are available are only to control the intraocular pressure. So all the treatment options that we have, whether they are medical, laser, or surgical, are directed towards reducing the intraocular pressure. We should understand that managing glaucoma is not difficult. We know that glaucoma is not a specialty that is, kind of only specialized people treat, but several people, several general ophthalmologists and comprehensive ophthalmologists actually treat glaucoma patients. So essentially, when you say treatment of glaucoma, it means reducing intraocular pressure. But what is important is to understand how do we treat and how much do we treat all these patients. For example, if there are about 4 patients who present at the same severity of the disease, do we treat all of them similarly? This is a question that is there that most of us need to answer, and I think I will take you through the presentation for you to understand that it is not similar. Ultimately, our aim is to maintain the visual function for the patient's life term, and our treatment as such should not affect the patient's quality of life to a maximum, in the sense like your treatment should actually help the patient or not trouble the patient in any way. The doctor's concerns are what is the mechanism of glaucoma, how much IOP do we need to reduce, what is the rate of progression of glaucoma in this patient, is this patient taking treatment properly or not. While we look at the patient's problems, they have multiple hospital visits that they have to worry about, multiple drugs that they have to use, and a lifelong treatment, or a blinding disease, associated comorbidities. There are a lot of other issues. I think there should be a sync between these two, and we should not just treat the intraocular pressure, but treat the patient as a whole and also help them to rehabilitate visually as well as psychologically. There are multiple groups of drugs that are available as far as the glaucoma treatment is concerned. And the question often asked is, how do we choose these the treatment options? Meaning, like, what is your first line treatment? What is your second line treatment? So we look at the efficacy of the drug. We look at how much is the dosing and how many times do we need to use it? What are the local and the systemic side effects? And if we have to choose 2 different drugs, are they synergistic or not? Once we decide to treat them medically, we need to know about the medication very well. So there are basically medications that we use, the drugs that work on the inflow, that means decreasing the inflow of aqueous. The other group of drugs are the ones that increase the outflow of aqueous, either through the trabecular meshwork pathway or through the uveoscleral pathway. Which drugs do we choose? I'm not going into the details, but essentially we need to understand that when you choose to use a drug, the first drug of choice or the first line therapy should be a drug that has the maximum benefit as far as the efficacy is concerned. To use the drug and has least side effects. Of course, cost is an important factor, but I think with the generics that are available in our country, cost is not a major issue nowadays. So first line treatment is essentially PG analogs or beta blockers, or second line treatment could be any of the other drugs that I have mentioned, and the third line treatment. But please, as a first line, second line, and third line all the time. For example, if a patient is allergic to prostaglandin analogs and is an asthmatic, your first line drug could be a topical carbonic anhydrase inhibitor. So you choose the drug based on the requirement for the patient. A lot of things we need to remember also is, apart from the efficacy of the drug and the side effects of the drug, what is the duration of action? What is the peak effect and the washout effect? This is very important, especially if you have to understand when you have to call the patient back to know the efficacy of the drug. A commonly asked question is about target intraocular pressure. As a postgraduate, you will sometimes be confused. Should you bring down the pressures for all patients to 12 and 13 or 14? Or is 15 okay, or sometimes even if 20 pressures are okay? So what is important is to understand that target intraocular pressure is not a fixed number. It is a range of pressure under which the patient's disease does not progress. It depends on the severity of the disease. It also depends upon how the nature of the disease is progressing over a period of time for this patient. And this could be dynamic, which could change from time to time. For example, if 14 millimeters of mercury is a pressure under which the patient did not progress for the last 5 years, let's say, and now suddenly see that there is a progression. You have found out that the patient is using medications very well, everything else is okay, but the disease is progressing, which means that you may have to possibly try and reduce the intraocular pressure or change your target intraocular pressure to a lower level. How aggressively do we treat? We don't treat everybody similarly. We treat them based on a lot of factors. So is the disease early or not? Is the patient old or young? And is the disease progressing very fast? So multiple things that we need to look at. So it has to be a tailored approach. For example, if intraocular pressures are not very high, we can also observe or treat them with a single medication. Versus a young patient with an advanced disease and a very high intraocular pressure, we may need to treat them aggressively. So the target pressure, the health status of the patient, life expectancy of the patient, affordability and compliance are the factors that we need to consider before we decide on what is the best option available. Remember this is from a systemic drug where people have looked at the number of medications and how well are the patients adherent. So if somebody is more than 3 or 4 medications per day, or oral pills per day, their adherence comes down to less than 50%. Similar to that, even for topical medications, the more number of times you need to use the medication, the adherence will obviously come down. So we need to remember that. So hence, a combination treatment is something that we often use. So this is again a question that is asked: when do you switch treatment? That means when do you stop treatment and when do you add therapy? So a simple thing that we need to understand is, let's say if an efficacy of a drug is 25 to 30%, and if you're using this as a monotherapy, and if you have desired amount of pressure reduction, but that pressure reduction is not patient, then you know that the drug is working, but for this patient, this is not sufficient. Should you add another drug? While the efficacy is, let's say, 25%, but then for this particular patient, it is about 10 or 15%, and the IOP reduction is not as much as you expected. That means possibly this drug is not working. So it's time to think about stopping the drug and switching to another drug. So that's in simple terms to understand about switch and add treatment. Always start with the most potent drug. Combinations are usually helpful because it can bring down the number of drugs that they use, improve the compliance as well as decrease the side effect. When you choose to combine drugs, always choose with different mechanism of action. Aqueous suppressant, which decreases the inflow, as well as one, let's say, a drug that increases the uveoscleral outflow like a PG analog. So the best example I can tell is a PG analog and a beta blocker. This is something that's very important when we explained, unlike the oral medications, we tell the patient take a pill and they know they have to take a pill with water or without water, they just swallow it. But as far as the drops are concerned, it's very, very difficult. Where you just tell them, use this 3 times a day. The 3 times could be morning, afternoon and night is what you are thinking, but patient may just use it from morning until mid-afternoon. All the 3 times they may finish it up because that is their convenient time. So tell them how many times they need to use it, tell them the spacing between the drops, how they apply it, and after they apply the medication, to close the eyes and keep a finger to press in the nasolacrimal sac area so that the drug doesn't get into the systemic circulation. So you can decrease the systemic concentration as well as the side effect to a great extent. Whenever the patient comes back, let's say a month or two after you started the medication, if the drug does not, if the IOP is not come down very well, you need to understand that apart from the fact that the drug may not be working, it's also possible that the patient is not instilling the drop appropriately or has not been compliant, or your diagnosis maybe we need to relook at. So it's very important not just to start them on treatment and give them a prescription, but I think it's very, very important to tell them how to use it and how long to continue and what are the problems that are associated. So always try to take the family into confidence, educate the patient, because this is a chronic treatment, and you know, especially with glaucoma, treatment alone is not going to improve their vision. So most often they are confused as to why they are using it, and even with treatment they don't see any kind of a benefit. So they may tend to stop medications. We need to explain it and tell them that this is the reason. The reason why we are treating is to stop progression, or at least preserve the vision with which you have been diagnosed with. Visual rehabilitation of the existing vision is very, very important. Explain to them about the home environment, explain to them that there will be decreased contrast, and that going out at night, especially if they are going out alone, may be very difficult. Mobility training, and also with the amount of vision that they have, what else additionally you need to do to help to improve their quality of life, as well as to use their vision to the maximum. I'll just take you through a few examples. A young lady who was diagnosed to have glaucoma, diagnosed as ocular hypertension actually, on 2 medications, was with intraocular pressures ranging between 21 and 28, CCT in the normal range, open angles on gonioscopy, and this is the OCT which shows red everywhere. Discs are healthy, visual fields are normal. So essentially this is ocular hypertension. The question is, should you treat or not treat? Is this glaucoma? First of all, this is not glaucoma. Like I said, there is no disc and nerve damage. What do? We need to definitely make sure that this is, we are not missing out on any other diagnosis. Always recheck the intraocular pressure, and if it is done with an NCT, recheck it with a Goldman applanation tonometer, because NCT, we know that it overestimates the intraocular pressure. So what I would like to share is, if you have a patient with an NCT IOP that is high, always suspect that it could be high, so always recheck it with a GAT for you to diagnose what the intraocular pressure, whether there is glaucoma or not, or whether the IOP is really high or not. Why was this? This is something that you need to know. You can't treat based on an OCT. OCT could be abnormal because of multiple reasons, especially in high myopes, wherever there is a structural abnormality, or in very large discs, advanced glaucomas, and those with media opacities. So do not start treatment based on an abnormal OCT or based on an NCT IOP. OCT being a structural test, any structural abnormality, you can have an improper or an improper image acquisition. You can have a bad quality image and an abnormal OCT. Another lady, middle-aged lady with with established glaucoma, you see that there is a disc hemorrhage superiorly with a notch, and you have an inferior field defect. Patient is a hypertensive on medication with a positive family history of glaucoma. CCT is on the thinner side. What I would like to emphasize is this patient has glaucoma, no question about it, no doubt about it. But patient is on antihypertensive. So antihypertensive medication, especially beta blockers, if you have, before you diagnose somebody as having an NTG, always rule out use of oral antihypertensives. This is very important. And at the same time, this particular group of patients may not be beneficial if you're using a topical beta blocker. We may need to use a different class of drug. All hypotensive lipids, your dosage is usually once at bedtime, except for uniprostone, which is used twice daily. For the benefit of postgraduates, I thought I'll just touch upon these 3 new medications that have come to the market. That is the latanoprostene Bunod, Rocklatan, which is a Rho kinase inhibitor, which is Ropressa, which is a Rho kinase inhibitor, and Rocklatan, which is a combination of these 2. This is something that you need to maybe keep a watch on, because it could be it could be an exam question, or they could ask you. Rope is a drug which is used again once at night time, increases the trabecular outflow as well as decreases the aqueous production. One of the side effect being congestion. So it again is as a different group of drugs apart from a PG analog. Up to 6 weeks it takes for you to know the full effect of the IOP lowering that happens with this drug. The other drug that is available in the West is Vyzulta or latanoprostone Bunod, which is a drug which has a latanoprost, which is the drug which is available. It also has a moiety that donates a nitric oxide once it is instilled in the eye, which also increases the trabecular outflow. Roclaton is a combination of these two. CCT is very important when you're trying to treat the patients for medical treatment. You know that thin corneas underestimate the IOP with GAT and thick corneas overestimate IOP. This is something that you need to remember before you start somebody on treatment. Another question is, when do you treat an ocular hypertensive? Somebody with a 24 IOP, do you treat? So you definitely have to do a CCT in these patients. Make sure that if the cornea is thin, you will treat. If the pressures are very high, beyond 30, you will definitely treat. If there is a family history of glaucoma, you will definitely treat. Or if there is glaucoma in the other eye, you will definitely treat. One-eyed patient, you will definitely treat. Otherwise, you would maybe observe. Some of the side effects of medication, very typical spotter of a periocular dermatitis caused by brinzolamide. Brimonidine, which is available, either it is available as Alphagan or it is also available as a combination with beta blocker as Combigan. Another common problem that is with the drugs, you can have a conjunctivitis-like picture or sometimes a pseudopemphigoid-like picture with the drugs. So sometimes you need to understand if somebody with a chronic conjunctivitis but a known glaucoma patient keeps coming back to the emergency again and again, always rule out a drug-related toxicity. The same patient after surgery, you see that the ocular surface is so much better and patient's pressures are well controlled. So drug allergy is something that you need to remember, always remember. This is something that all of us know. There is hypertrichosis as well as trichomegaly with the PG analogs, change in the color of the iris as well as the periocular skin. Side effect that we need to definitely explain it to the patients, especially if they are young patients, is periorbital changes and deep upper eyelid sulcus that happens with prostaglandins, which is called as prostaglandin-associated periorbitopathy. What do we do in children? Most often, the medical management of glaucoma in children is surgical. However, in some secondary glaucomas and in JOAGs, medical treatment is effective. Topical CII, carbonic anhydrase inhibitors are the primary drug, followed by beta blocker, and PG analogs and alpha agonists are sparingly used. Drugs in pregnancy, if you see first, second, and third trimester, I'll just take you through this table. No drug is safe that way if you look at it. But having said that, many of these young patients who are JOAGs if they are pregnant, then we need to understand what do we can you use and can we continue the drugs that the patients are already on. So in the first trimester, alpha agonists are quite safe. Second trimester, most of the topical medications are okay. Whereas late in pregnancy, we have to make sure that we avoid alpha agonists. So this is just to take you through. And key points, intraocular pressure lowering is definitely effective in the management of glaucoma. Target IOP is not a number, but it is a range, and you need to keep adjusting that based on how the patient's disease behaves. Prostaglandin analogs definitely provide better diurnal intraocular pressure control. Combination therapy is very useful, not just for IOP lowering, but also improves compliance as well as decreases the side effects related to the drug as well as especially the preservatives. And achieve target pressures with the minimum medications and minimum side effects. Take care of the patient as a whole and do not hesitate to move on to surgery if the medications are not helping to take care of the glaucoma. Thank you for your attention.
Thank you, Dr. Shrisha Sendil, for an excellent presentation. You took us through the entire medical management of glaucoma. Excellent. I think you gave us pearls and the clinical scenarios. I think the PGs would have really understood how to go about it in a case of a glaucoma, how to treat them. Thank you so much. It was an excellent presentation. Dr. Thanush Dada is unable to join us today, so will not be having the session on glaucoma surgeries. Hope you all enjoyed day 3. Tomorrow we have a very important day which covers up the difficult topics, strabismus and neuro-ophthalmology. And we'll be having imaging, OSCE, as well as instruments. So hope to see you all tomorrow at around 6 in the evening. Bye-bye and good night.
We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone.